Honorable members, we now allow a moment of silent prayer or meditation. Thank you very much. You may be seated. Honorable delegates, I'd like to remind delegates that rules, in particular sub-rules 21, 22, and 23 of Rule 103 would apply. In accordance with Council Rule 2291, there will be no notices of motion or motions without notice. Honorable delegates, before we proceed to questions, I'd like to take this opportunity to welcome the ministers from the social cluster, specifically the Minister of Health and the Minister of Social Development. Honorable Ministers, you're always welcome in the NCOP, and we thank you for joining us here today. I also want to welcome all the permanent delegates, MECs, and all special delegates and SALGA representatives to the House. I'd like to remind delegates that in terms of Rule 229 of Council Rules, the time for reply by ministers to a question is 5 minutes. Only 4 supplementary questions are allowed per question. A member who was asked the initial question would be the first to be afforded an opportunity to ask a supplementary question. The time for asking a supplementary question is 2 minutes. The time for reply to a supplementary question is 4 minutes. The supplementary question must emanate from the initial question. I now call upon the Honorable Minister of Health to respond to question number 25 as asked by the Honorable Finis, and the question deals with the recruiting and or retaining skilled staff. Honorable Minister.
Thank you, Honorable Chairperson, honorable members of the House. Honorable member, in your question, you are alluding to the fact that there's failure to absorb new medical graduates. I want to assure you that on that one, there is no failure at all. Every newly qualified medical student is placed to do internship in a hospital accredited for that purpose by the Health Professions Council of South Africa, HPSA. This internship is statutory for all South Africans who have studied medicine. Without internship, the life of a doctor comes to an abrupt end. You cannot go into private practice. You cannot work in a public hospital. You cannot study further. You are simply stuck forever. For this reason, every South African who studied medicine has to do internship, and the state is obliged to make money available for their salaries. After they have completed the internship, which takes 2 years, they are then obliged to do community service. This was introduced early on in our democracy because doctors had so many choices of jobs that they refused to go to rural areas. So in order to make sure that every hospital in the country, whether urban and rural, does have a doctor, the concept of community service was introduced, whereby each doctor after internship will be obliged to do that community service, which is also statutory. And we made sure that this community service is never practiced in an urban area, but only in rural areas, sometimes maybe peri-urban areas, but not really in the centers of cities. Now, the problem we're having about employment is not internship and community service, because those are statutory. Even Treasury knows about that. The problem we have is after community service, because there, in terms of the law, a doctor must then apply for a job just like any other graduate, any other. But we have soon realized that society does not get used to that fact, but also because our populations are growing, we are trying our best to make sure that we advertise doctors' jobs so that they don't remain unemployed. Now, the last question about whether we are using any measure to ensure that unemployed health professionals, such as doctors and nurses, are recruited to serve rural areas. I can assure you that's no longer happening. Yes, it used to happen some years back where people refused to go to any rural area. There's no doctor who will dare do that now because jobs are in short supply. Any job you advertise, it doesn't matter in what part of the country, the health worker will have to pack and rush there because that is a job. So we no longer, that's why, as I'm speaking in front of you today, we've put together a team to review some of the HR policies that we used to have. One of the HR policies was something called rural allowance, where we're paying health workers a special allowance for working in a rural area because nobody wanted to go there. Now we believe it no longer has a function because doctors go, I mean, not only doctors, health workers go wherever there's a job these days. Thank you very much, Honorable Chairperson and Honorable Member.
Thank you very much, Honorable Minister. We now go to the follow-up question, and the first follow-up question from the Honorable Finis.
Thank you, Chairpersons. Greeting to the Chairpersons as well as the Honorable Member. Thank you, Honorable Minister, for your response to my question. How effective is the department in distributing new qualified healthcare professionals to respond to service delivery needs?
Just come again, how?
How effective is the department in distributing newly qualified healthcare professionals to respond to service delivery needs?
Thank you.
Thank you very much, Honorable Finis. Honorable Minister, your response, please.
Oh, sorry. Yeah, I can assure you without any equivocation that we are very, very efficient in that regard. We start as early as February. Even now we have started for next year. We get a list of all the final year medical students from our universities and we start placing. And it's very difficult, Honorable Member, because as I'm saying, even though I'm saying doctors go anywhere because it's a job, they prefer urban areas. And I can tell you with my eyes closed, they choose Cape Town, they choose Johannesburg, they choose Pretoria. After that, you start having some bit of problem. They'll tolerate eThekwini, Gqeberha, and East London, etc. From there is a disaster. All of them want to be crowded in one area. Remember, those central areas are the areas that are accredited mostly by the Health Professions Council because that's where professors are, that's where equipment is. You can't do internship in an area where there are no senior people and there's no equipment because what are you going to learn? So they crowd in those areas. So what we do, we give them 3 choices. That this is choice number 1, choice number 2, choice number 3. Some, when they come to choice number 3, they already refuse. But after the 3 choices in the first round, we give them a chance to lodge a complaint. It might be a complaint. Some lodge it on religious ground, others on social ground, that I've got a mother who's very sick, is about to die. I can't leave this area. I'm the only one taking care of her. I'm just giving you an example. Some quote marriage, and many other social things as to the reason why they can't take the choice we've given them. But in the final analysis, we complete that. And by September every year, the young, newly qualified doctors have got to know where they are going to acclimatize themselves. We have been able, I must accept, after many years of trial and error, to finally get it right. For the past 2 to 3 years, by September, they already have letters of appointment. So that system is very effective because people have got used to it and they know exactly what happens. But still, I must warn, We have got people who prefer not to work for 6 months because the intake for internship is in January and the second intake is February. Some prefer, obviously, is those who come from richer families who can go without a salary. They prefer to wait that 6 months for the second round until they get the place they want. But they won't say so. They will come to you and the press and say, I've not been placed for a job. And of course, you'll always believe them because we'll always get attacked. There's nobody who will say, there's a job, but I don't want to go there. They'll say, I've not been replaced. Many of them go to their unions. They've got lots of unions who go to the press, and the press always oblige about the state lying. But I want to assure you, internship is statutory. We cannot afford to have an intern not working because their life will have come to an end. And that's the biggest evil that we can ever do to anybody. Thank you very much.
Thank you, Honourable Minister. We now go to the next follow-up questions. And the follow-up question is from the Honourable Billy.
Thank you, Deputy Chair. Minister, very troubling and contrary to what you are saying, provinces like KwaZulu-Natal have still got a number of unemployed qualified doctors who are protesting. Now, the question also raises other challenges, Minister. And the question, the follow-up question to you is, in 2009, the staff in Chris Hani Baragwan had a meeting with you about staff issues. This is over 10 years ago. About staff-related issues. However, your response makes it sound like it's a new issue. Why did the department not do more at the time? The question to you, Minister, is that there were issues which were raised pertaining to the question that has been raised with you by the staff in Chris Hani Baragwana in 2009, 15 years ago. And the question is, why haven't you done more to address some of those challenges raised at the time at a meeting that you had attended at that hospital at the time?
I'm not sure.
Thank you very much, Honourable Billy. Honourable Minister, your response, please.
I'm not sure what you want. I've just told you that over time we perfected this system because of meetings like those where we meet doctors, they tell us their problems, they tell us. Now we eventually designed an electronic system of placements. That's why I can stand here confidently in front of you and say each and every intern is placed. As to whether they would like to go there, that's a second question. But we do place them. We make sure that they've got a job. It is true that in KZN, doctors do it as elsewhere. And 2 weeks ago, because of this problem, I asked to meet the Premier of KZN, the MEC for Finance, and the MEC for Health. And we spent 4 hours with them and their teams. This is one of the things that we're discussing with them about how to solve them and how do they affect the healthcare system. So we did. So about your 2009 question, surely you can't accuse me for not having done something some years ago when it has been resolved. I am telling you now it has been resolved. In September this year, every medical student who is a South African will get a letter about their placement. That I can assure you. As it happened this year, you never had any intern complaining at the beginning of this year because they were placed last year. And unfortunately, last year, I must concede, we placed them in October, not in September, because KZN was delaying. That's why I had to go and see their premier to show them the effects of that delay. Because of their delay, we only placed them, but in October. By October, they were already having their letters. Thank you.
Thank you, Honourable Minister. The next follow-up question is from the Honourable Sawisa.
No, thank you. Thank you, Deputy Chair. Minister, despite the means to recruit more nurses and staff, it cannot be addressed without having proper health facilities, especially in rural areas. The question that comes to mind is, are our health practitioners equipped to handle the advanced equipment? What plans are put in place to ensure that our health practitioners can operate the latest equipments despite them being recruited to work in rural areas?
Thank you, Honorable Suisa. Honorable Minister, that question doesn't really relate to retention of an appointments, but if you want to answer that, you may
Yeah,
do
you can
so.
answer it. You can answer it. Honorable member, it depends what equipment you're speaking about. That's why we have got 4 types of hospitals in the country. We've got the district hospital. That's the smallest hospital you can ever have in the country. We have got the regional hospital. Those are the hospitals. Unfortunately, the terminology seems to be confusing. Those are the biggest hospital in each of the 54 districts of the country. We call them regional hospital. Then we've got the tertiary hospital. That is the biggest hospital in that province. Then we've got central hospitals or academic hospital. Those are hospitals attached to medical schools where doctors are trained. We have got none. We have got 2 here of such hospitals in the in the Western Cape. We've got 1 in the Eastern Cape. We have got 2 in KZN. We have got 4 in Gauteng. But we have none in Mpumalanga. We have got none in Limpopo. We are just building it. It's at 40% completion. We have got none in Northwest. We have got none in Northern Cape. Now, those 10 academic hospitals are the ones where you find sophisticated and very expensive equipment that can only be operated maybe by professors. For instance, an equipment like what you call magnetic resonance imaging or MIR. It can see a tumor in your brain the size of a head of a pin. It's not every doctor who can operate that. You need to be highly trained as a specialist radiologist in order to do that. So you are not going to go to a small district hospital and find an MIR machine. It has to be where there are well-trained people. But we do have what we call point of care technology. As technology gets advanced, which you can even put in a clinic. For instance, to diagnose TB, it used to take us many weeks, even up to months, just to diagnose TB. But since a gene expert technology come, you can put a small gene expert machine even in a clinic, because all the nurse need to do is to get your sputum, put it in the machine and wait for results. Whereas in the past, you needed a specialist to get your sputum, do what is called a culture, do what is called gram staining, and look into the microscope to see those organisms. Only a well-trained eye could do that. But as technology moves, that has passed. So, Honorable Member, the answer to your question, it depends what level of technology. And you can't put a very highly sophisticated technology in a hospital where there's no trained staff member or there's no trained specialist for that technology. But you can put a point-of-care technology even in in primary healthcare clinics and centers. Thank you very much.
Thank you, Honorable Minister. The next follow-up question is from the Honorable Briet.
Thank you, Honorable Deputy Chair. Honorable Minister, you've said a lot and everything is quite worrying. You've spent a lot of time talking about how we place interns, and I can still to this day tell you from experience and from people that it is not so easy and so clear-cut and so effective as you yourself are admitting to this House today. But maybe let me get back to the initial question, and it was, how do we retain staff and how do we absorb the new medical staff? And my problem is, I come from the Free State, it's very rural. We have a problem with retaining our medical professionals at our in our rural areas, in eKwakwa, at Boitumelo, list all of those. And one of the main reasons is due to poor infrastructure, bad infrastructure, telephones not working, equipment not being up to date, certain operations that can't be done because we don't have the technology in those district hospitals or in those clinics or wherever. So my question to you is, what concrete steps are you and your department taking undertaking to ensure that we are upgrading these facilities in our rural areas to assist our doctors and to help retain them, because I think that is our biggest problem. They don't want to work there because they have nothing to work with. I thank you.
Thank you, Honourable Member. Honourable Minister, your response, please.
Thank you. Thank you, Honorable Chair and Honorable Member. Honorable Member, I can assure you, and I insist, the system of placement of interns is working very well now. But what I cannot guarantee is to put an intern where they like to be. That one is difficult because I told you the fight for particular places. I know interns and from here, in the Western Cape particularly, they were known to wait for 6 months and not work at all for the next intake because they don't want to leave Cape Town and go elsewhere. That one we are not able to solve, and I've alluded to that. But that we are able to place each and every one of, at the moment, there are close to 2,800 who qualify every year. We are able to place them. Secondly, those who have completed their 2-year internship and become community, community service, we are also able to place them. And I've considered that the problem starts after community service because it's no longer statutory. It's a person looking for a job like any other profession who must look at the newspapers for a job that is advertised and apply for it. That is how the system works. Now, about the issue of having no equipment and all that, Honorable Member, you know, we discuss that issue every day when we meet with MECs because, you know, everybody believes health is a concurrent competence. And they'll say it's concurrent, means it's practiced nationally and provincially. I want to assure you, there are 4 functions that are never concurrent. They are pure provincial competencies. That is HR, who you hire and where you put them and all that. It's not concurrent. It's a pure provincial function. That works like that in health and even in education. The second thing that is never concurrent is financial management of equitable share. The money you read in equitable share and send it to a province, once it arrives there, I've got no control over it. The province can say whatever they want to do with it. The third is procurement. I don't control procurement in any province except to nudge. And the fifth one, as you're saying, is maintenance of infrastructure. We try our best to make sure that we discuss these issues when we meet in the National Health Council, which is our MINMEC in health. And because it is a problem. And we have tried in the NHI Act to reverse this type of things because over the years, we've seen how problematic they are. The federalization of health. And yes, I was a doctor also, I know, and I've always informed them. Please put good infrastructure, even accommodation. Many young doctors are attracted by accommodation. If the accommodation is good, there is TV, even good food. I can assure you, you may believe it's a small thing. I remember when I did final year, I spent 2 weeks at Nongoma Hospital and I was alone. There were 2 of us, sorry. As medical students, there were no doctor there except one army doctor. It was very comfortable to stay in Nongoma because they gave us good accommodation and good food. You are always looking forward and you realize here I can serve. So it is small things like that which sometimes provinces just ignore. That makes doctors to go away. And we discuss them every day and we'll keep on doing that. Thank you.
Thank you, Honourable Minister. That concludes question number 25. We now go on to question number 41 that was asked by the Honourable Duplessis, and it deals with the issue of morbidity. And we'll ask the Honourable Minister to respond to that question.
Yes, the Honourable Member is asking that now that in the past decade, the leading causes of death, causes of morbidity, let me correct, not mortality, morbidity, that they are changing. And the Honourable Member is right. You are very right. the leading causes of morbidity in our countries is changing. Ordinarily, in underdeveloped countries like ours, countries in the global south, it was generally known that morbidity is caused by communicable diseases like HIV, AIDS, TB, malaria, cholera. All the infectious diseases are known to be the leading cause of morbidity in the developing countries. Whereas in the global north, in the highly developed country, the pattern is the other way around. They are generally suffering from non-communicable disease like high blood pressure and strokes, cancer, diabetes, and chronic respiratory illnesses like asthma. Now, honorable member, the developing countries like ours are undergoing what scientists call epidemiological transition. We are in the middle of a transition, meaning that we are starting to get the diseases that were regarded as diseases of rich people in the global north. We're also starting to get them. So while we are used in South Africa, for instance, to be having the highest rate of HIV infection, but we can now pick up that cancer is developing very fast. It's becoming our new HIV/AIDS cancer and is killing our people. Diabetes is developing very fast. High blood pressure is also developing very, very fast. So we're in the middle of that transition, which means we need to change certain things. And what do we do? Because your next question is measures that we are doing to strengthen confidence in the public health service. We are doing measures to control diseases, honorable member. And the top of the range is prevention and control, especially of non-communicable disease. The mainstay of solving cancer and diabetes and high blood pressure is to make it not happen. And for that reason, it needs prevention and promotion of disease and promotion of health, screening, early detection. Secondly, we do this screening every time, this time, cancer, hypertension, diabetes, etc. These activities are supported by community health workers. And I'm happy to announce to you that since December last year, we are in a process that must end at the end of March to absorb 27,000 community health workers and make them permanent, because previously they were coming through NGOs. We are also implementing a mass communication strategy. If you watch TV these days, we have got quite a number of adverts about stopping these diseases in the mass communication. Thirdly, we have got a program called CCMDD, meaning Central Chronic Medicine and Dispensing Distribution, to try and reduce the number of people who have to queue every day, people who are on chronic disease, especially HIV, AIDS, and TB, who are sort of stable, who don't have to be seen by a doctor. We discourage them from coming to hospital every time. And how do we do that? They give us an address of an area where they can collect their treatment. That's why we call it a Central Chronic Medicine Dispensing and Distribution. Then we give their names and the medicines to a service provider who will package the medicine, look at the address, and go and deliver it there. As I'm speaking here in front of you, 3.5 million South Africans are on this program of Central Chronic Medication and Distribution. We have just implemented a new program called 6MMD, meaning 6 multi-month dispensing, where people have to go to a clinical hospital only twice a year, because we give them their treatment, which will keep them for the whole 6 months. The last issue we are doing, which is the center of controversy and war, which is coming here soon to you, is control of things like sugar, salt, smoking, alcohol. And when we do that, because we know their effect on human health, we start fighting each other, because some of you are lobbied about the loss of work and collapse of factories and all that. I'm saying it's coming to you because we are debating a tobacco bill and we are going to hear all these stories. But we know that tobacco has got 15,000, 70,000 rather, no, 7,000 chemicals. When you light a cigarette, it produces 7,000 chemicals. 70 of them
Thank you, Honourable
have been
Minister.
proven to cause cancer.
Your time
But we're
was
still
expired
debating.
on that response. Thank you.
Thank you.
We then move on to the follow-up question from the Honourable Duplessis.
Thank you, Deputy Chair. Honourable Minister, thank you for that answer. And it seems that a lot has been done. However, in the past 20 years, non-communicable diseases have increased by 58.7% in South Africa. I also think that using a developing country or the fact that we are a developing country as an excuse is not enough of an excuse. When countries like Spain in 1950s were seen as developing countries, and within 20 to 30 years of shifting their healthcare system, they were able to exponentially decrease non-communicable diseases as well as trauma-related diseases. This works when a public healthcare system is run by ministers who implement international best practice. Minister, it's a difficult question to ask, but how can South Africans trust a public healthcare system that is not improving in morbidities with the minister leading it? Thank you very much.
Thank you, Honourable Duplessis. Honourable Minister, your response, please.
I don't know what excuses you are talking about. I gave no excuses. I gave you facts. And these facts were given, I think, at United Nations in 2015, where they put two types of disease together, country by country, to show which country is suffering what pattern of diseases. And it became very clear that the global north countries are suffering from disease of lifestyle, diabetes, etc. And the global south are suffering from disease of infection. That has been outlined at United Nations. It's not an excuse, it's a fact. Now, even at that time, South Africa was already straddling in the middle. We're already going through this transition. It was starting. Now we are in the middle of that transition. And that's why we're doing something about it. I don't understand why you say it's an excuse. We're doing something about it. We're saying instead of waiting, for instance, for people to get cancer, let's look at the things that cause cancer. And number one of them is smoking. Let's control it. Let's regulate it. Because we know, as I was about to finish here, Chairperson, my time ran out. I want to release this. Here we've got the cigarette, which when lit releases 7,000 chemicals, and 70 of them cause cancer. Why should we go on with that type of thing when we know that treating cancer is so difficult and so expensive? Then comes diabetes. Then comes the things that are caused by alcohol, etc. All those things we are putting in front of you and say, honorable members, help us to control these things. Why are we having a new tobacco bill now when there was a bill passed by the First Minister of Health in a democratic South Africa, Dr. Nkosazana Dlamini-Zuma? It's because after she came with that bill, industry found something else. They found new ways of nicotine delivery called vaping. You know, this vaping and all that, which is killing our kids. And they say, no, the act doesn't say vapes, it says cigarettes. So we are coming back to say, let's include the vapes because they are destroying our people. Then salt. High blood pressure is mostly driven by salt. It's mostly driven by salt, which also causes kidney diseases. So we started long ago. It's not now. We started long ago. We called industry. We found that South Africans are eating 4 times more salt than their body needs. So they are eating what their body doesn't need, but what they desire, not what is necessary. And we gauge in which foodstuffs do we found salt. We identified 6 foodstuffs. The first of them was bread. Many of us wouldn't even know that bread has got more salt than it's supposed to have. Then it was brining in chicken. Then it was soups. Then it was spices. Then it is, things like peanuts and all the other things, So we called industry and say, please, you are going to destroy our people. At that time, in Gauteng only, there were 500 people who were waiting for dialysis because of kidney damage. We said, please control the amount of salt. They said, no, Minister, we give it to you to regulate us. because the smaller ones will hide behind the bigger ones. We regulated it and agreed with them that we'll reduce salt in these foodstuffs every 3 years over a 9-year period. We have done so. Bit by bit, we're reducing so that people don't riot when they believe they are eating saltless food. And we've arrived there. In September last year, the United Nations, by the way, gave us a prize for that. At UN in New York, we received a prize for the work we did for reducing salt because we are dealing with these non-communicable diseases. Thank you very much.
Thank you very much, Honorable Minister. That was very good information for us to take back. The next follow-up question is from the Honorable Feni.
Thank you very much, Honorable Deputy Chair. Thank you very much, Honorable Minister, for the capacitating and empowering responses. Yeah, shungalithathu emlanjeni bawufuna ulisela alizokusela Minister. Honorable Minister, is there any improvement in service delivery since the implementation of the National Strategy Plan for the prevention and control of non-communicable diseases? Thank you very much. Come again.
Did you say none? Non-communicable?
Non-communicable diseases.
Okay, yes.
Thank you very much, Honorable Feni. Honorable Minister, your response, please.
There is somebody here who believes you gave me these questions before. I heard that in the National Assembly. You can't just believe that we know answers to these questions. I heard a similar thing. Nobody gives answers before. That's why even everybody from any party can ask a question. And I'm inviting you to do so. We'll answer them. If we don't know, we'll tell you we don't know. We won't lie. Yes. Okay, thank you. Yes, anyway, look, there is progress, but this is very slow all over the world. It's a problem, Honorable Member. Non-communicable diseases are diseases of lifestyle. And most of the things that cause, they don't really have a direct cause, non-communicable diseases. We actually gave them a nickname. We said they are diseases of 5 by 5 because they are mostly 5. And the factors that encourage them, not directly cause them, are also 5. The non-communicable diseases are high blood pressure, is diabetes, is cancer, it is mental health, and chronic respiratory disease. And the factors that drive them are also 5. Top of them is cigarette, smoking, followed by alcohol, then diet, as I've mentioned, sugar or salt. Then you also have environmental factors, the environment in which you are staying. Now, those things are very difficult to change because they are entangled in people's lifestyle. For instance, we can't ban sugar because you need it in your body. But the problem is your relationship with sugar, which has changed. What do I mean by your relationship with sugar has changed? When we grew up, honorable members, some of the sugars we used to see them only on Christmas. Those who are my age here will remember only on Christmas you see Exa. You remember Exa, you know? Yes, then you'll see it in the next Christmas. Oh, these days, you go to a funeral, soft drinks. You go to a wedding, soft drinks. You go to parliament after meals, soft drinks, you know? And people don't know that those soft drinks are actually dangerous. They ask you, when did they become dangerous? A 300 ml tin of Coca-Cola has got 12 teaspoons of sugar in it. If you go home now, you find your child hiding behind the house with 12 teaspoons of sugar on the hand and leaking, you are going to assault them. When you come from parliament where you just took that can of Coke and swallowed the 12 teaspoons of sugar, but you are going to assault your child and say, and all that, you know. These are the problems that we are faced with and the world is faced with. And let me tell you where our fear is. We had this pandemic of HIV and AIDS. We got a lot of help from other countries. PEPFAR, even when they pulled out, they helped us for 20 years. Global Fund, etc. I can assure you when it comes to non-communicable diseases, there's no country that will help you. No country is going to give anybody money to deal with diabetes or cancer or high blood pressure. It's not going to happen. That's why we need to solve the problems now, because you are not going to get help like we did with HIV and AIDS, especially that they are not communicable. With HIV and AIDS, countries help you sometimes not because they love you, because they are scared that you will take the disease to them. Like you saw what happened during COVID, where we had to close borders and all that. So they help you for that. Why should anybody help you when you have got diabetes? It's yours only. You're going to go down alone, not with any other person, on your own. And that's why we need to be very careful how we deal with these diseases. Thank you.
Thank you. Thank you, Honorable Minister. The next follow-up question is from the Honorable Mampuru.
Thank you, Deputy Chair. Minister, you have partially responded to my question. However, I will request that you give further clarity onto it, that despite the existing policies and awareness programs, which specific intervention have you implemented in the past 5 years to reduce the burden of non-communicable diseases in the public healthcare facility, and whether you have conducted any assessment to determine why these diseases remain prevalent among poor and working class communities who rely on public healthcare system?
Thank you, Honorable Mampuru. Honorable Minister,
Let me start with the last question, the last part of the question. Why they affect poor people is because, trying to solve non-communicable disease can be expensive. When we start retreating you, don't eat this, eat that. Don't eat this, eat that. Now you can choose. Poor people cannot choose, if you understand what I mean. They eat what is available, not what the doctor has told them to choose. And that's where the key of the problem is, that those who are well-to-do do have a choice, and those who do not, eat whatever is available. Even when you tell them that, look, you're not going to tell a poor person not to drink what you call Coke or cold drinks. If they get them in a waiting, they're going to swallow it. You are not going to tell them not to drink excessive alcohol. If they found a bottle of alcohol in a party and all that, that is one of the problems that we're faced with. That is why we have got to go on to a good communication strategy. Now you ask me what we have done in the past 5 years. I've just told you before that we reduced the amount of salt in food, 6 foodstuffs. And we are very proud of that, because it has reduced the number of people who get high blood pressure, kidney diseases, strokes, and all that. We have done that. We also came with the sugar levy, and we were attacked because people said we were raising funds by taxing people. The sugar levy was not for raising funds. We don't even care much about that money. It was to discourage people taking a lot of sugar, as I've told you, because sugar is becoming a new poison to our people, unlike in the past when sugar things were so scarce. So we have tried to tax it. And honorable member, just get into a restaurant, a supermarket, and see what has changed there, which you have to deal with. In the past, you used to get into a supermarket, fill your trolley, go directly to the point and pay. Now it no longer happens like that. And it looks like a decoration. It's not a decoration. They want to Pavlov you. When you finish your trolley, you are going to move into a passage. This way, that way, that way, and that way until you reach the till. Just look what is there in that passage. It's sugar. It's sugar, which on your list of groceries, it's not there. It's not there, but they Pavlov you. Pavlov is a Russian man who came with this thing called conditioning. He's a Russian scientist who noticed that people get conditioned. You can condition a dog, even a human being, by enticing them, So they entice you, they put chocolates, everything that is there is sugar. Even if you don't like it, if you have got a child, you are going to buy it by force. That child won't leave you when they move into that passage. So try to leave them at home, because they are going to make you buy. Yeah, you see now. Yeah. Thank you. Yeah. Yes.
Point of order, Chair. The minister is using props in the house.
She is
Honorable
currently
Buttonwas, do not
Pavloving
disturb the
me.
minister, please.
She is Pavloving me. That's how they Pavlov you in the restaurant. Thank you, Honorable Chair.
Thank you, Honorable Minister. The last follow-up question on this question is from the Honorable Finis.
Thank you, Chairperson. Thank you, Honorable Minister. The public healthcare system in South Africa remains highly unequal, serving approximately 84% of the population, while the private sector caters for the remaining 60%, but consumes over 50% of the country's total health expenditure. Is the government making progress in engaging all stakeholders to explain the need for an urgent move to fully implement the NHI to address the two-tiered system, which continues to severely limit equitable access to quality healthcare and perpetuates deep inequalities in access to healthcare between the poor majority and the well-off? I thank you, Chairperson.
Thank you, Honorable Member. Honorable Minister, your response.
Honorable Member, you are right. According to the World Health Organization, if a country spends at least 5% of their GDP, not budget, GDP, if you spend 5% of your total GDP on health, the World Organization has calculated that you are likely to cover all the citizens. Yes, but that is only in the books. In the real life, it's not like that. Because South Africa is already at 8.5%. We are far, far above a lot of countries in our total healthcare expenditure as a percentage of the GDP. For instance, in BRICS, we are number 2. We are beaten only by Brazil, which is spending 9.8% of their GDP on health. We are number 2 at 8.5. Very rich countries and developed countries like Russia and China are below us. Russia is still at 7.6. China, I think, is 6 point something. India is even worse. They are not even at 5%. But all of them beat us in terms of the health outcomes like mortalities. Why? This thing has stopped. Chair, this thing has stopped. So I can speak forever.
Table, staff.
Please, darling. Yes, I'm not going to. That's why I'm warning them. I'm being honest. Yes, yes. So the reason in South Africa is because in that 8.5%, 51% of that goes to only 16% of the population, as you said. In fact, in our figures, it's 14, but not much different between 14 and 15. And 49% has to be shared by a whopping 86% of the population. That is what is called gross inequality. If you want to see why we say South Africa is the most unequal country in the world, come to health. There's gross inequality, which makes it very difficult to meet what we want. Now, people tell me this is private money. The money in private care is private money. Why do I meddle with it? It's not true. The state subsidized private health care very heavily because everybody who gets their salary from the state, starting from the president, anybody whose salary is from the state, it doesn't matter where you're working, starting from parliament to a factory, as long as your salary is from the state, that person is heavily subsidized. And the total subsidy is 70 billion rand. 70 billion. On top of that, each person who is on a medical aid, it doesn't matter who their employer is, they get tax rebates or tax subsidy. And before last week, when the budget was read, the total tax rebates from SARS was 33 billion. In other words, every year, 103 billion rand that helps private sector is from the state. And the poor don't have any access to it. And my heart was bleeding last week during the budget when this tax rebates of 33 billion was increased. I'm sure it's going to go to 35 or 37 billion. So these are the things that we seek to respond to. Well, people will tell you, no, you are lying, it's corruption. I'm not going to sit here and argue that there's no corruption. We've seen it and we fight it every day. Some will tell you that no, it's incompetence. We have seen some of these incompetencies and mistakes that happened, but we can't deprive the majority, 86% of the population. Now, because of this skewed, honorable member, skewing, people go and queue and we get insulted. Let me give you an example. 80% of all the psychiatrists of this country are in the private sector. There are only 870 of them in the whole country. 80% are in the private sector because it's natural that people follow where there's money. There is a private hospital in the center of Johannesburg. It has got 57 gynecologists. What is the significance of that number? Mpumalanga, Limpopo, Northwest, all added together, they do not have 57 gynecologists. They can't raise them because all the senior gynecologists go where there's money is. So this gross inequality is causing us problems in South Africa. And it's one thing that we need to sit down and resolve. We can't run away from it. Thank you.
Thank you very much, Honourable Minister. That concludes question 41. We now move on to question number 26 that was asked by the Honourable Masumpa, and it deals with the status of medical legal claims. Minister, your response, please.
Yes, on the issue of medical legal cases, the following information collected from the provinces provide an update on the matter. In the Eastern Cape, the NPA is considering evidence. The Directorate for Priority Crime Investigation investigators are gathering additional evidence as instructed by NPA prosecutors. Maybe let me start here, honorable members. You'll remember that in August 2024, we have a joint press conference with SIU about this case of medical legal. Medical legal cases stems from negligence in the healthcare system. But I can tell you, we found that some of them is just absolute fraud, unfortunately, by lawyers. And when I said so some years ago, they were saying I'm hiding behind them. It has been apparent now. Some lawyers have been struck off the roll because of this practice. There is a lawyer in the Eastern Cape who put in claims for 15 children who he said have got cerebral palsy. What made me suspicious is that cerebral palsy is not a uniform condition. It doesn't cause uniform disability. There are different disabilities, but you are charging the same amount of money. Same amount. 25 million for each. 25 million for each. We sent the SIU there to investigate. Firstly, they visited the schools where these kids are. And the teachers were surprised to hear that so-and-so is supposed to be disabled. Then they went home to the Magogo. They found that most of these kids are staying with the Magogo. Magogo, you signed the power of attorney for this lawyer to hire to sue the state because you said the child is disabled. Magogo would say, me, the things I've signed here, people who came here from SASA, they told me they are from SASA, I must sign here for the child to get child support grant. So I signed. She doesn't know that she's giving power of attorney. They went further to investigate and found that some of the kids were never born, they don't exist. But they are taking advantage that in the Eastern Cape, and that's happening in other provinces, the records cannot be found and all that and all that. That's why we're even trying to repair this issue of records. We have now to try, as part of fighting that, honorable members, we have gone to CSIR to ask them to give us an IT system that can help us trace a patient from one doctor to the other, from one healthcare system to the other, from clinic to hospital. And we said, do a system where we don't have to pay tax. I mean, not tax, rent. You know, all this IT system, you are paying rental for the owner. We said we want a system owned by South Africans. CSIR went to work. It took them 8 years, but I'm proud to mention they've now finally designed such a system. We have tried to pilot it in the Tlhabeng, in the Free State. We are now rolling it out. That system is directly linked to Home Affairs. When you go to a hospital, you just give them your name and ID, we press. Home Affairs will tell us immediately who you are and you know where you come from and all that. So those are the systems that are going to help us trace. At the moment, we're still struggling from time immemorial. That's why people can go collect medicines from one healthcare system to the other, from one clinic to the other. They just collect medicines. The doctors and nurses won't know that this person was next door collecting that medicine. So it makes this medical legal also worse because lawyers know, some of the lawyers even know that you can go and sue in one court and sue for the same patient in a different province in another court. They've got no way of knowing. That system is going to help us, and that's why we're so excited about it. Thank you very much.
Thank you, Honourable Minister. The follow-up question will now come from the Honourable Masupa.
Thank you, Deputy Chairperson. Thank you, Minister, for responding to my question. Does the department have any mechanisms in place for early detection of stopping corrupt law firms from instituting illegal claims against the department? Thank you.
Thank you, Honourable Member. Honourable Minister, your response.
Yeah, Honourable Member, in 2015, we called all the role players, private sector, public sector, doctors' associations, nurses, and even the legal profession. We had a conference about this medical legal. What do we do with it? And we drew a series of points that need to be followed. One of them was that we need to make people as safe as possible inside hospitals so that there is no medical legal. In other words, make sure that you reduce the number of mistakes we do. But the reality, and I'm just giving you this reality as a fact, the World Health Organization once disclosed that when you are inside a hospital, sorry, let me put the other way around. When you are inside an aeroplane flying in the sky, you are 300 times safer than when you are in a hospital. Because in a hospital, anything can happen. Any mistake can be done. You can be given an overdose. Somebody can be doing a diathermy and burn you. Somebody can cut where they were not supposed to cut. These are the dangers, but we said we must put mechanism to resolve them. Now, as I'm speaking in front of you, we have chosen hospitals in each province where we realize a lot of this medical legal is coming from. We're going to visit them one by one, just to see what is that which they can do in this hospital. Why are so many cases emerging from here? For instance, as I'm standing here in front of you, in the Eastern Cape, we know is Nelson Mandela Academic Hospital in Mthatha. Very unfortunately, a hospital named after Madiba. That's where some of these things are happening more than in any other. We are going to visit there and see. But the second thing is this filing system, which I've spoken about. That's why I'm telling you CSIR took 8 years, because after that conference, we took a resolution that makes sure that you resolve the issue of filing so that it must be electronic. You just press and you follow this patient throughout the system. Whether the patient today went to a public hospital and tomorrow went to a private, they must be able to know it's the same patient and be able to link them. We are doing it. The other things we are doing, which is a big difficulty in court, we've just lost a case in the Eastern Cape 2 weeks ago, that this lump sum payment, you see what lawyers will do is say, this child is now disabled because of what the healthcare system has done to this child, the right for future medical care, and that future medical care is calculated on what a private hospital is going to charge. And you give that lump sum of money. Once the money is paid, that child will never see the gate of a private hospital. They come to the same public hospital. Yes, some right housing, that this child disabled, the wheelchair, need a ramp, you need a house worth 4 million rand and all that, and the judge agree. That family will never see that type of a house. The best they can do is an RDP house from the state, you know. So we have got all these type of things, and that's why we are working with SIU forever, not on a, like calling a press conference once. We work with them every day and say that money must go to the people who are sick. And we are saying, if a child is disabled, give us as a court what we need to do for that child and let the public do it. Because if they go private, that money is just going to disappear there. There's no question about it. It's the truth. Many of you have been to private hospitals, you know that. So we try in that, and but the bottom line is, can we reduce the level of negligence inside the hospital such that there's no medical legal? Thank you.
Thank you, Honourable Minister. The next follow-up question is from the Honourable Swart.
Thank you, Honourable Chair. Good afternoon, Honourable Minister. Welcome to the House. Chair, I'm glad that the member has asked this question, the cases that was being referred to the NPA. Minister, you know that the case of the 3 health department officials the President suspended now recently, I think it was yesterday or the day before yesterday, that is made to the NPA. While we welcome the suspension, even though it took the President to intervene for the Minister to act, can you as Minister indicate whether these suspension will carry with full pay until the matter is finalized within the criminal justice system, which could take years, or whether the Minister will ensure internal disciplinary matters? Thank you.
Thank you, Honourable Member. Honourable Minister, your response, please.
You are aware that this has got nothing to do with medical legal, but I'm prepared to answer it. Yes, I was laughing because I told somebody that this is what is going to happen. Because there is a newspaper called News 24, which has got a gripe with me because of NHI. And everything that happens in my department, they twist it. I laughed yesterday because I issued a statement about this suspension. And I know the words they've used, but they used the word after directive from the President. I wrote a letter to the President, me. I said, Mr. President, this is what happened in my department. Because in terms of the law, remember this even came from the courts, ministers cannot deal with DGs to employ them or to suspend them and all that. Only the President can do so. We then met in the cabinet and said the President cannot do so much work alone. He has got other issues of heads of state. What he must do is to delegate. And we developed a delegation pattern, whereby the President must sign that delegation and give it to you. I wrote to him last week and said, Mr. President, give me delegations because I need to suspend my DG who unfortunately has been arrested. I got those delegations formally on Friday evening, and I decided to get the weekend to pass. After the weekend passed on Monday, I had to do what the laws of the country demands. Do an audio letter, Paja. There's a law called Paja in this country. We passed it in Parliament, where a thug has to be asked if you must act on them. That's what Paja says. Yes. Can you tell me why I shouldn't do this to you? This is how Bushiri destroyed us. Because when I was in Home Affairs, the moment I discovered that his permanent residence is fraudulent, somebody tipped me that even Omotoso, who is being charged in Eastern Cape, has got a fraudulent document. We wrote to Bushiri immediately because we proved that it was fraudulent. Now, Paja force you. Honorable Bushiri, can you tell me why we shouldn't take back something that is yours? You are asking a thug who stole it. And he immediately rushed to court and said, the Hawks have arrested me, I'm going to appear in court. Now this department wants things from me, which are my defense. And the judge agreed and said, no, don't take that. permanent residence. Even today, he's still keeping it. He's a permanent resident of South Africa because I couldn't get it. So anyway, that's Paja. So I had to do it on Monday, and you give them some time, and they responded on Tuesday. And on Wednesday, which is yesterday, I issued a statement. And the newspaper which you read, which I suspect they were going to, saying after a directive from the president, in other words, showing that no, this minister was not willing. He had to be directed. That's not true. They do that all the time. Even when a problem happens somewhere, they put my head there. When in the Free State, they hire a guy who has been in jail as a CEO of a hospital. It's my head that was there. And yet it has got nothing to do with me. And that goes on and on and on, especially with News 24. Whenever they write a story about me, they skew it in such a way that I must be seen as some piece of rubbish and all that. So I laughed when I saw their story about this suspension that I was instructed by the president when I'm the one who asked him to give me the delegations to do so. And I did it. Thank you.
Thank you very much, Honorable Minister. The next follow-up question is from the Honorable Gericka.
Thank you, Chairperson, and good afternoon, Minister. I must say it is commendable that you understand the issue of delegations of power. And it is commendable that you requested the President to give you the delegation. We've been struggling with many ministers that do not understand the delegation. They're just there in the chairs and they don't understand. Now, having said that, the DG in your department is in serious trouble because I see the charges are fraud and corruption together with other senior officials. Can you unambiguously this afternoon, not in the by the way, tell us that his suspension has got nothing to do with medical? I know that you've mentioned it now, but you've mentioned it in the by the way. But state emphatically it's got nothing to do with medical. And also that there was no undue influence from his side, for instance, on the NPA to delay the matter that we have at hand here. Having said that, Minister, given that these matters are long outstanding and repeated requests for responses have fallen on deaf ears, and that these matters are in the interest of the public interest and deserve to be treated with urgency, what measures have you put in place to receive regular updates from the NPA, and what were the responses? Thank you very much.
Thank you, Honorable Member. Honorable Minister.
You are aware that we formed an anti-corruption forum in health, which takes all these law enforcement agencies. And that anti-corruption forum meets quite often. Health is part of that and the informers. But these suspensions were specifically based on the charge sheet, which was brought by the Hawks to me in my department on Monday afternoon, after my DG and two other officials appeared in court. They put the charges there of fraud or corruption, etc. It is on the basis of that I went to ask the president to give me delegations for the DG, for the other officials, because they are DDGs. It's a CFO and a DDG. Both of them are at DDG level. I needed no delegation from the president. I did it on my own. Yes, I did it on my own because I've got the rights to do that. But these newspapers that is crying about NHI all the time will never say so. Yes, after a directive and all that, there was no directive. It is something that I needed to do because I'm the one who knew what happened. The other case, which you seem to be talking about, which has been postponed by SIU, you are aware that we don't interfere with SIU decisions. We are also waiting to hear what the SIU is, the NPA is saying, because you are aware that the NPA might decide to charge or not to charge a person. And they are supposed to be taking that decision independently without us interfering. Thank you.
Thank you, Honorable Minister. The last follow-up question is from the Honorable Mslongo.
Thank you, Chair, and greetings to you, Minister, once again. I believe you've covered most of my the questions that were answered, but I'd like to know with regards to the issues that we're facing in Eastern Cape, where there are illegal matters that are arising from medical legal. Has the department managed to create a program to ensure that you educate people from the rural space? Thank you.
Thank you, Honorable Mslongo. Honorable Minister, your response.
Are trying our best to educate people about these things, but you can imagine it's a very difficult thing because poor people are dealing with lawyers who are highly educated, if you understand what I mean. Like these poor gogos which gogo will refuse to sign if you tell him, Gogo, I'm coming from SASSA. They don't know what color SASSA people are. They just see an official wearing a suit and a tie and say, I'm coming from SASSA, sign here. That gogo is going to sign. So it is us who are educated to make sure that we don't use our education to cheat the poor. In the Northern Cape, Honorable Member, we had a lawyer who went to court on behalf of this child and was granted 19 million rand. 19 million. But he was paying that family 6,000 rand per month out of the 19 million, which he has kept in his trust account. And the family get only 6,000, if you understand what I mean. We had very heartbreaking cases of a man who is on a wheelchair and the lawyer claims the money for him and is giving millions. And you give that poor man on a wheelchair, you give him 50,000 rand or even 100,000, which he has never seen. We had heartbreaking cases where the poor old man takes part of the money to buy a cow and thank the lawyer. The same lawyer who stole his millions. Now, these are very painful things which happen. And when I said so, it's not because I'm bashing lawyers. The fact remains that it is true, it is there. Why do they do that? Even cheating children who are disabled. You remember the other painful thing, Honorable Chair? Let's say this child has got cerebral palsy. The judge gives 35 million, which is the amount that attracted them some years ago, 35 million. The lawyer is entitled to 25% of that money. Yes, in terms of the laws now, 35%. I mean 25%. Many of them don't take that 25%, they take much more. And my question has been this: who is going to enjoy life here? This child with cerebral palsy whose brain is damaged, 35 million is not going to bring the brain back, it's not going to enjoy this money. It is the legal representative. And why do they even go on to cheat when they've already got an advantage of this? We do have, and it's happening now, I'm not lying. The case of this 35 million I'm quoting is what was charged by a judge in Gauteng who was angry because the province was not responding very well to the charges, and he gave 35 million. And that lawyer came out with 9 million rand from that money. And from that case, lawyers are going to schools and places of disabled, looking for disabled children to come and sue. Especially that the Constitutional Court had a ruling that cerebral palsy cases don't transcribe. That means they don't expire until after 20 years, which means if it would have happened 20 years ago, you are still allowed to litigate. Whereas other cases, they tell you that the period is transcribed. Since they've known that, oh, I can go for the past 20 years, they are busy searching. They even have scouts, people who move around the villages scouting for disabled children in order to sue the state, and knowing very well that they are going to take part of that money. So that's the problem that we are faced with human beings, unfortunately. Thank you.
Thank you, Honorable Minister. That concludes question number 26. We will now move on to question number 45 that was asked by the Honorable Mslongo, and the question deals with the rollout of the new HIV vaccine. Honorable Minister, your response, please.
Honorable Member, I wish to clarify upfront, there is no HIV vaccine currently approved for public rollout in South Africa or anywhere else in the world. We don't have an HIV vaccine. Scientists are still searching. There are, however, several candidate vaccines that are going through trials at the present moment. I'm not very sure, Honorable Member, I'm just guessing whether this issue of a vaccine could have been confused with lenacapavir. Lenacapavir, which we are going to roll out, is a game changer in the fight against HIV and AIDS because clinical trials have shown that for young girls who are the ones that are, victims of HIV/AIDS in large numbers, it protects them 100% as long as they take that injection every 6 months. That's why the president had to announce it in the State of the Nation, because we want the nation to take interest. Very soon, he is going to launch it personally, to launch lenacapavir. As long as that young girl takes the injection twice a year, they are protected. Men having sex with men, they are 96% protected. So whichever way is worthwhile, but it's not a vaccine. It's a PrEP, it's pre-exposure prophylaxis. Vaccines, we are still looking for them, but when we look for vaccines, Honorable Member, they follow stringent procedures. Stringent procedures. We even have a special committee of ethics that must decide whether you can go and do trials with these people on human beings. We've got serious protocol approval issues, informed consent, adverse event monitoring, and independent oversight as set out in the South African Good Clinical Practice Clinical Trial Guidelines. It is there and is regulated by South African Health Products Regulatory Authority. So we are not just going to do, tests with human beings without going through all these things. So at the moment, all the HIV/AIDS vaccines are still what we call candidates. They are going through these phases. And every vaccine must go through phase 1, phase 2, and phase 3. Only at phase 3 does it go into the bodies of human beings in a form of a clinical trial. So that one is very strict and is something that scientists follow very closely. Thank you very much.
Thank you, Honorable Minister. We go to the Honorable Mslongo for a follow-up question.
Thank you, Minister, for the clarity. Thank you, Chair.
Oh, so there's no follow-up question. All right, we then move on to the Honorable Sibande for his follow-up question.
Thank you, Chairperson. Thank you, Minister, for your superb responses, which pushes me to suggest to the Chairperson that to allow you to give us a free lectures every month, if possible. But nevertheless, let me go to my question. Has there been any breach of ethical and scientific standards in clinical trials that took place in the past? That is my question.
Thank you very much, Honorable Sibande. I know that the Minister wouldn't mind giving us a free lecture, but you'll have to take it to the programming committee first. Honorable Minister, your response, please.
The reason that science have come up with these protocols is because it is tempting, Honorable Member, for a scientist who wants international fame to make use of human beings as their guinea pigs in order to come with something that they believe will save the world and is in their name. For that reason, they put up these very clear protocols. I can't off my head, Honorable Member, remember that, but there are many cases. I can't remember a specific one off my head. There are many cases. That's why they are taken to statutory bodies, to scientific bodies, etc. If you remember last week, we had a press conference with scientists, regulatory bodies, including the World Health Organization, about this scare that was sent out, if you remember, about sanitary pads and panty liners. You remember the scare that took place 2 weeks back? About more than 2 weeks back. We had to call that press conference. Professor Ntobe Guntuzi, who is the president and CEO of South African Medical Research Council, complained there and says scientists ought to know the protocols and procedures when you do research. And how do you make it come out to human beings? Because remember, that thing caused a lot of anxiety and fear among women for no apparent reason. And he said, there are protocols, there are steps, there are ethical things. That's why there are ethical committees. And maybe you don't know, no scientist is allowed to do a research on something that affects human beings. Maybe the problem with that study in the Free State, it had nothing to do with human beings. It did not even come from a medical school. It came from a department of analytical chemistry, which has got nothing to do with human beings. Maybe that's why. But for those which have got a lot to do with human beings, you don't just start doing a research. You apply to the research committee in each university or to South African Medical Research Council. And I say, I want to do this type of research. The ethics committee will look at the ethics you are going to follow, and they may say no. They may not allow you to go on. So no research is just done where human beings are concerned, where you just wake up and say, I'm going to research on human beings, because that will be very, very dangerous, because human beings are not the same. I'm sure many of you know the story of a gentleman called Basson. Yes, Wouter Basson. Many people were saying, no, that man is very brilliant. We must use it somewhere. There was nothing brilliant. All the things he was doing to kill people in Namibia, I know them because we use them in theater. But because we are using them ethically, I can't do what he has done. All the things he was injecting people, we inject people under control conditions in theater when you put them to sleep. You know, you don't just inject a person who is not under oxygen because you know they are not going to breathe, they are going to die. So those things scientists know. The question is, are you ethical? And that's why you have got to apply to ethics committee before you do any research. Thank you.
Thank you, Honorable Minister. The next follow-up question is from the Honorable Duplessis.
Thank you very much, Deputy Chair. Honourable Minister, it is reported that lenacapavir has been approved by SAPRA, as you've stated, and the rollout will happen in April this year. What is the rollout plan? How will it be implemented and monitored to ensure fairness and efficacy? Thank you very much, Minister.
Thank you, Honorable Duplessis. Honorable Minister, your response, please.
Yeah, thank you very much. We said, fortunately, late last year in what we call a round table, where we brought all stakeholders, including international partners, philanthropists, we said and said, this lenacapavir, how are we going to do it in a way that is fair, as you say? Because the first 988 doses are going to be donated by the Global Fund. That's a donation. And I'll tell you why we have to have that donation. Lenacapavir is brutally expensive. It has been there in the United States. It costs 28,000 rand per person. There's no $28,000, man. Why do I say rands? Which is close to $500,000, yes. So Global Fund negotiated from the company that produced it, Gilead, to give it to them, and they are buying it for us for $29 million. Those are the first doses, which means they will cover about 450 people only. If there are 488 doses, for about 445 or 448 people, they will cover them. So the question is, who do we start with? After that round table meeting, we agreed that we start with young girls, not young boys. Young girls, because they are the ones who are carrying the brand of HIV/AIDS infection from sugar daddies. We know that. We've got graph statistics have shown up. So the young girls are the ones who are going to be the first. Then after young girls, we are going to give it to pregnant women so as to protect the unborn child, pregnant women and lactating women. From there, we are going to go to breeding populations. Breeding populations being what? Sex workers, men having sex with men, because they are also the ones that are a bridge between our communities. So those are the ones we'll start with. Fortunately, the question was then, after this donation, where do we go to? We have already chosen 350 facilities where we are going to start. These are facilities in very high burden areas. Now, the next question is, what do you do after that? Fortunately, when we were in New York during United Nations General Assembly in September, the Clinton Health Access Initiative, headed by former President Clinton, plus a company called Dr. Reddy's, plus our own vets, RHI, they came together to sponsor a motion whereby Gilead will give a voluntary license to companies that will produce this lenacapavir at a cheaper rate. Maybe then the question will be, what will be a voluntary license? If a pharmaceutical company has researched a particular medicine, be an injection or whatever, or a vaccine, they are given 20 years intellectual property rights. For 20 years, they are the only ones who can manufacture that and sell it at whatever price they choose. After 20 years, that intellectual property lapses, anybody can produce it, and that's called the generic, which is usually cheaper because we never spend money on research. So on this one, Gilead was approached by many people around the whole world on the basis of ethics and say, look, we have got this thing that costs 28,000 rand that can save humanity. Why make it so expensive? So Gilead agreed to give voluntary licenses, and 6 companies were given voluntary license. They are going to produce it at $45 from 28,000. You can imagine. They are going to produce at $25. So that will come in the market in 2027 or 2028. And it means as many South Africans as possible will now be able to get it. Thank you.
Thank you very much, Honorable Minister. The last follow-up question is from the Honorable Kennedy.
Thank you, Honorable Chair. Honorable Minister, talking about that scare, it reminds me back of during COVID time, where we were told that this is a method of killing Black people. I didn't sleep that day of my vaccine because my whole hand was sort of numb. I said, this is the way now. So with reference to the vaccine hesitancy peaking during COVID-19 at around 30 to 50%, Minister, how does your department plan to address potential social harms because our mind were harmed, like the stigma, the discrimination, the fear that may arise from the vaccine trial participation in our communities? And in the event of serious side effects, what legal and medical support structure are in place for the volunteers? Thank you.
Thank you, Honorable Kennedy. Honorable Minister, your response.
Yeah, Honorable Member, volunteers are very highly trained people. They train them what to expect and what's going to happen, and nobody is forced into voluntarism. For instance, there is a very promising vaccine for TB. TB has never had a vaccine for more than centuries, not decades. There is a promising vaccine that is being tested in 7 countries or 7 centers. They are testing it on 20,000 people. 13,000 of them come from South Africa. It's South Africans who volunteered and say, we want TB to go. And they sit with them, they sign agreements. They don't just meet you on the streets. They sign agreements, they know what they are going to get into. They actually are taught what to expect, and they are followed up, because the company that is producing this is going to be required when eventually that thing is registered. It's going to be required. You know, when you take a packet, let's say a box in which there are pills or a bottle, inside it there's a small leaflet, right? Scheduling category and all that. That leaflet will have a list of side effects or possible side effects. You can't put that medicine on the market. Every human being must read. Even Panado, go and read. It has got that scheduling, pamphlet, which mention how does it work, what is it going to do to you, what are the possible side effects. Anything that, even if it happens once in a million, they put it there for you to know. So that company must monitor all the side effects because they are going to be required. And when they register that medicine with SAPRA, South African Health Products Regulatory Authority, this question SAPRA is going to ask. It's going to ask you, did you do this? What are the possible side effects? How are they going to be counteracted? And you as a company, you must answer. That is why researching some of these medicines can take as long as 20 years. It can. The measles vaccine that was produced many years ago took 40 years to develop because of this type of things. But now, because science is getting more and more advanced, it takes as short a period as possible. But the issue of side effects is very important. After all, honorable member, when doctors give you a medicine, they weigh. In economics, you call it a cost-benefit analysis. Whether when I do business this way, I'm going to gain more or lose more. In medicine, we also weigh. Is the damage that this medicine going to cause, is it bigger than the benefits? If yes, then we won't give you that medicine. But if we know that the benefits are higher, even if there's a possibility of a damage, we give you. Just like the drugs that they give you for what you call chemo. You know chemo. Yes. You get getting lean, your hair, you know. Yes. Lose appetite, you lose and all that. But we have got to give you it because the cancer is going to kill you. If on the other hand, we realize that this chemo is going to be more dangerous than the cancer itself, then the doctor shouldn't give you that medicine. So he's trying to reach a balance about these things. Thank you.
Thank you, Honorable Minister. Now we come to question number 45. Asked upside down. No. Question number 47. Asked by Honorable Makesini. Deals with the backlog on what paid orthopedic surgical backlog.
Yeah, this is about the backlog of orthopedic cases in Cecilia Maguan Hospital. Honorable member, I said earlier that hospitals differ. We have got district, regional, etc. Cecilia Maguan is a regional hospital, which means it manages only non-complicated trauma cases requiring orthopedic intervention. Currently, when I developed this question last week, there were 25 trauma patients who were admitted and awaiting surgery. All the other cases are referred to Freer Hospital because it's a tertiary, it's a higher level hospital, because Cecilia Makiwane cannot do complicated things. Now, orthopedic surgical procedures are divided into two. We've got emergency procedures. Ordinarily, there should be no waiting period to do emergency procedures because an emergency is an emergency. Now we have got elective procedures. Elective is where you go and book and say, I want to do a new replacement or a hip replacement, etc. There's no emergency hip replacement or emergency knee replacement. It's a procedure for which you can book and there's waiting time. Now, there are people who believe that no, there's a medically determined waiting period. Waiting periods, unfortunately, depend on availability of resources, both human resources, infrastructure, and equipment, and it differs from hospital to hospital. But at the moment, for Cecilia Makiwan, for a waiting period in the case of adults, that means anybody who's more than 13 years old, is 2 to 3 weeks, because that's what the question is saying. For children under 13, there's nobody in Cecilia Maguan who's skilled to do orthopedic surgery on such children. So they are all sent to Free Hospital. And so it doesn't, the question doesn't apply in that case. Sometimes limited theater time, as I said, mainly due to no shortage of nurses. Now, honorable members, let me say this to you, which is a very painful thing for all of us in the world. There are 4 types of specialist nurses who are in demand all over the world. We call them, they've got a critical skill. It's an ICU nurse. A nurse that works in ICU all over the world, they are chasing them because they are highly skilled. It's a theater nurse, a nurse who is in charge or works in theater. It's a high care nurse, and it's a psychiatric nurse. These 4 are in high demand. Now, theater nurses are in such a high demand in both public and private. Many of them actually refuse to be employed. You'll never give them a job, even if you advertise 100 times, they don't. Rather, they join agencies. Agencies look around the country, which hospital wants that nurse that night or that week or that day. And so they give them to the highest bidder. They choose. In other words, they've got a free choice that I want to go there and there I can't go. So they don't usually want to be employed. And that's one of the biggest problems we're having. And if they want to go overseas, they are grabbed immediately, especially in the Middle East, where they've got a lot of money for oil, but they don't train a single nurse. They just come to our country and grab them. So now, this is what Cecilia Maguan is suffering from. However, they've appointed 6 additional general nurses. But these are not theater nurses, they are general nurses, which means via Zamazama to make sure that these operations go on. Because a theater nurse you won't easily get. But they've also approached the agencies that is keeping these nurses to make sure that they do help so as to clear the backlog. You ask a question about surgical implants. Cecilia Magiwane does not do procedures requiring surgical implants because that is advanced surgery. So the question doesn't apply to them. Thank you.
Minister. The next follow-up question will come from Honorable Makesini.
Rosandas. Thank you very much, Minister. Ndiyabulela ngokuphana nge-direction and noku-educate. I-question yami ke ngokuthi senza njani ukusebenza i-department ukuthi to educate abantu bayazi i-role ye-regional hospital lapho bazatransferela khona because bonke ba-expecteka besibhedlela bacima bazo-operatwa abazama zabani basebenzisayo to educate abantu ukuba bafundiswe baxelele ukuba i-progress ukuba bayanjani ukuba bangatransferela to the higher hospital. Thank you very much.
Honorable member, we try our best, and it's ironic that the question is about Eastern Cape. Because people in other places, people know, but they don't like it. For instance, there was a time when Eastern Cape, I suspect even now, has got more hospitals than any province. And when we check now, we found that they actually named any facility where somebody's wearing white things, they call it a hospital, even if it's very tiny. So that's why in 2010, we said and say, let's have a scientific classification of a hospital. And we said any facility that has got less than 50 beds must not be classified as a hospital. And those who are classified so, they must lower their standard to a health center. I can tell you it's difficult because communities will tell you to go to hell. When you tell them that, no, we made a mistake, they say we all want that hospital. Everybody wants a hospital of the highest order, even where people are very few. So it's a very difficult thing for which we should not make mistakes, because once you do it, you'll never correct it. People will go up in arms. I remember in my own area where I came from, in Skukune, there were 2 hospitals there, 10 kilometers from each other. One was then built by the former Leboa government. You know, they put up new wards, they renovated and all that. And the other one, they didn't do anything. And it's the one that was regional. So we had Dr. Joe Pasha became the first MEC in Limpopo. So she had to tell them that, no, this hospital is well built. It has got a lot of infrastructure. It must be regional. I can tell you there was war. and they thought it had something to do with me and him, even though I was not in health, because we once worked in that hospital. Dr. Patla at some stage served as a super. We all worked there. They said, yeah, these two guys worked there. Now they are in government. Because they worked in that hospital, they want to make it a regional hospital. We're making it regional because it had facilities. It was rebuilt. They bought new things. They renovated. Ndate Phala is St. Rita's Hospital. Yes, I'm talking about to him because he's from there. When we moved and Sagen first doesn't have these facilities, it must be a district hospital. St. Rita's Hospital must be regional. There was nearly a Third World War in that area. But these are how human beings are. They all want to have the highest, but we're trying our best. So the solution is, let us not make mistake when we classify hospitals, just to please our people. Because when you come to change, they are going to get very angry. Thank you.
Thank you, Honorable Minister. The next follow-up question will come from Honorable Feni from the Eastern Cape. Honorable Feni, it's your turn.
Thank you, Chair. Thank you once again, Honorable Minister, for your capacity session. Honorable Minister, are there any norms and standards for the waiting period of the patients waiting for these operations? That's my question.
What do you, Minister?
Well, thank you very much. Ordinarily, we wouldn't like anybody to wait. There's no human being who would like to wait in a queue. You don't want that. Whether it's in Home Affairs or in a bank or SASA, waiting in a queue is just something that human beings don't want, and it's natural. And so we try our best that we reduce that. So nobody wants to have a waiting time. But unfortunately, reality has it that if you don't have enough staff, you don't have enough equipment, what do you do? For instance, at Steve Biko Academic Hospital, they've got only one professor of cardiology, and he doesn't have anybody below him. And the whole of Mpumalanga referred to that Steve Biko Academic Hospital. So there is going to be a waiting list. Now, as I said, there are no norms of how long people must wait, except for an emergency. In an emergency, there should not be any waiting whatsoever, because an emergency means exactly that. But in elective surgery, there is unfortunately a waiting period, but it differs from facility to facility. A waiting period in hospitals, central hospitals in Gauteng, cannot be like a waiting period in the Eastern Cape, because most of the specialists and people with skills, a waiting period here in the Western Cape cannot be the same as in the Eastern Cape, because here we have got very clearly well-equipped hospitals. But some of the things depend on the procedure. For instance, Groote Schuur is the first hospital, as you know, here in the Western Cape. It's not the first in South Africa, the first in the world that did a heart transplant in 1967. Even now, it is the only public hospital that is doing a heart transplant. So if you need it, everybody, regardless of which corner of the country you come from, you've got to come to Groote Schuur. Even in the private sector, for that matter, is the same thing. As far as I know, there are only 2 private sector hospitals in the whole country that can do a heart transplant. It is Mill Park Hospital and Dr. Christian Barnard, just here down the road, Memorial Hospital. They are the only ones. So on that one, even in the private sector, you are going to have to wait. So there are no norms except that it depends on facilities, it depends on the skills, it depends on availability of resources. But emergencies should not have a waiting period. Thank you.
Thank you, Honorable Minister. The next follow-up will come from Dr. Sker Kochel from the Free State.
Thank you, Deputy Chairperson. Minister, in relation to the backlog of orthopedic surgeries, Mr. Ntubeleng Mofokeng from Van der Bijl Park have been waiting for 6 months from the Free State Department of Health to finalize his health claim, medical negligence claim from the failure by the Bentombeni Hospital in Kroonstad, the hospital in Sasolburg, and Pelenomen Hospital. The department was supposed to finalize their claim on 6 February 2026. To date, he has not received any feedback, and the poor services rendered by these hospitals has caused Mr. Mofokeng to become unemployed, need a hip replacement, suffered greatly bodily deformities. So with this case of thousands of people faced, this has been in the forefront since 2021. Why is the minister not addressing this so that Mr. Mofokeng and 1,000 others can get the dignity they deserve? Thank you.
Yeah, honorable member, it will be difficult to respond to you because I don't know that case. I don't know the facts. Please give it to me so that I go and check what could happen. We do sometimes correct this type of things. And I usually tell hospitals when I correct them or my fellow MECs, because sometimes they believe I'm interfering, that we correct them to help the patient, but also, as I said earlier, to avoid medical legal. Because that very same person you're talking about can go and sue if there is anything wrong that they've done in terms of weight. So please give me that case. Let me go and check and see what we can do. Thank you.
Thank you, Honourable Minister. I think Dr. Skirchogen will do that according. The next follow-up will come from Honourable Brett from the Free State.
Thank you, House Chair. Honourable Minister, with all due respect, I don't think this question asks for us to be given a lecture on what the different hospitals are. Question number C says, what specific steps have been taken to address reported shortages of theatre time, specialized nursing staff, and surgical implants at such facilities? And I want to know from you, because as my colleagues from the Free State have mentioned to you, we are seeing backlogs. It's the end of the financial year, and not referring to surgical backlogs, but we're seeing availability of medicine because it's the end of the financial year also not being available. We're seeing anesthetics not being available. So, Honourable Minister, what concrete steps have you taken to address backlogs of orthopedic surgeries and the likes? Thank you.
Honourable member, I'm not giving you any lecture. I'm just stating facts, how hospitals are classified. Those who want to hear and appreciate the knowledge, they will. If you don't appreciate that knowledge, just throw it away. That's as simple as that. So don't get angry that I'm giving information because other people need it. Yes. Now, what are we doing? And the reason that I was giving you this information, because it can't be one size fit all. I can't put solutions in Bongane Hospital, in Velcom, in the Free State, the same solutions I put for universities in Bloemfontein, because the two hospitals are at different levels. So what are we doing? We try our best to make sure that we buy enough equipment for them. And we've discussed that equipment for an appropriate level. But we also try to push provinces to create specialist posts, because it's one of the weaknesses that we are faced with, that we don't have enough specialists. But we also push them to hire enough registers. Registers are specialists in training. This particular matter, I've gone around the country talking to premiers. As I said, the first premier I visited is the premier of the Eastern Cape with his MEC for Finance and MEC for Health. I put this on the table, that the reason that there's these serious backlogs is because we don't have enough registers from your province and not enough specialist posts. And you did not buy enough equipment. So I put it in front of them. From there, I went to Northern Cape. From Northern Cape, I went to Gauteng. From Gauteng, I'm going to KZN. From KZN, I'm going to Northwest. I've already warned them that I'm coming. We are putting these things in front of them. and say, look, if you don't hire enough registers, this is what's going to happen. So those are some of the steps we are taking. And those steps cannot be the same for each and every hospital. That's why I was explaining to you type of hospitals, which you call a lecture. Well, whatever you name it, but I have to tell you that because the solutions cannot be the same for all levels of hospital care. Thank you.
Well, thank you, Honorable Minister. It is true that more information is better than less information. And when we're addressing us here, we're actually addressing the country as a whole. So it's highly appreciated. So, Honorable Minister, we now go to question number 28, asked by Honorable Mukwile from Limpopo, the province of the Baobab tree.
Yeah. Thank you very much. Honorable member, the question says whether the president has taken a decision to reverse implementation of national health insurance as allegedly reported in the media. And I know which media is talking about. Yeah, I've already told you. Yeah, they usually do that. That was propaganda. Honorable member, the president has never taken any decision to reverse implementation of NHI. NHI is an act passed by Parliament. It also passed through this House. You passed it in 2024. Now, the president, for that reason, has got no power, no right to unilaterally reverse an act passed by Parliament. That cannot happen. Yes. What actually happened, which they call it a reversal, deliberately as a propaganda tool to demoralize people, what happened is this. It started with a directive from the Chief Justice. Because at that time, we had 14 cases against NHI. 14. The first of those cases was by an organization called BHF, or Board of Healthcare Funders, which is an association of a number of medical schemes. They were saying the president should not have ascended the NHI Act into law because there were many objections. He should have sent it to Parliament. The judge ruled that the president must give all the documents he used to assent. We appealed that case, and fortunately, the Constitutional Court allowed us to go directly to them, not to go through Supreme Court of Appeal. And they made the date of 26th of February to hear that case in the Constitutional Court, our appeal in the Constitutional Court. Now, at the same time, we went to the judges and said, look, we want all these cases to be consolidated. There are many, there were already 14. They are challenging the same thing. Why are we hearing them one by one? We say consolidate. And of course, they refused. The judge then said, I'm forced to have a hearing in court, in an open court. And she put the date of the 24th to the 27th for that hearing. While things were like that, something happened that changed everything. That made the Chief Justice to act. The Western Cape government, through their premier, put a case in the Constitutional Court challenging the NCOP that the work you did here was flawed to pass that act. They said the NCOP did not pass this. Yes, they said it's flawed, and they are challenging it. At the same time, the Board of Healthcare Funders only, also put their second case to challenge the National Assembly. They say the public hearings are flawed. So we suddenly have got two cases in court that are challenging the process. The Chief Justice then said, in that case, why should we hear all these 14 cases? Because the outcome of these two can change everything. For instance, if the Western Cape wins here in the NCOP, if they win on your challenge, it means there's no act. So whatever we will have had before, it doesn't matter who won. It's moot. It's cancelled, If BHF also wins in the National Assembly, then it means there's no act. So the Chief Justice then said, no, why should I hear a case in the 26th of February, which in very soon may be nothing? And she didn't stop there. She said to bring certainty, I'm putting a date of the 5th to the 7th of May to hear the case against NCOP and the case against National Assembly. So she has got a date, and she said, before that, why should I hear any other case? Because I can hear it and make a judgment, and in May, that judgment is moot. So she then said, I'm postponing indefinitely to hear this BHF case, which was supposed to be heard on the 26th. But she said nothing about the High Court cases. So there was going to be a High Court case on the 24th and 27th. The judge there said, look, why don't we follow the example of the Chief Justice? We are going to sit now from the 24th, 27th, hear everything that in May might be moot. So the opponent said, no, we don't trust the Department of Health. If we stop, they will implement NHI. We want to put it in writing that during that period, they won't go on to proclaim. The president was about to proclaim certain parts of the act. So I advised him that, President, don't proclaim this. We have agreed that we are waiting for the challenge against NCOP and National Assembly. From there, we'll go forward. That's what happened. Is that called reversal? I don't know.
Thank you, Honorable Minister, for the comprehensive response. The next follow-up question will come from Honorable Mkwile from Limpopo.
Ke go leboge modulasetulo, ke go leboge tona ya tša maphelo mo Afrika Borwa. Tona le tlhalositše go tletše gore ke nnete gore le le tona tša maphelo mo Afrika Borwa le mmušo o e tuleng pele ke Ntate Ramaphosa di ikemišeditše go tšhireletša seriti sa batho gore ba kgone go humana tša maphelo go lekana. Tona pušo ya ka e no ba e tee le le lekile go itlhalosa ya go bontšha gore ka mokgwa le tlhalositseng ka ona ke tshepa gore ga go phošo or go phošo gore le le mmušo le eme ka go implementa NHI ka lebaka la gore le bontšhitše gore le sa emetše sephetho sa Constitutional Court. Ke a leboga.
Honorable Mkwile.
A ke kgole gore ke potšišwe unless ke se ka e kwa gabotse monna. No,
let me just rephrase it, Rabos. I'm saying that thank you for responding to the question. My question to you is that is there any?
I didn't give you a chance to speak. I didn't.
Eh?
Your time had expired actually.
Okay.
I think it was a comment, Minister. You are not a co-chairperson, Mr. Panerost, please. I think it was a comment affirming the work done by the department in your government.
No. As some say, we're not stopping to prepare for NHI, by the way. We just stopped proclaiming. The president was about to proclaim certain sections. That is what the demand was all about. But preparations can't stop. In fact, you remember that the president announced building of 3 academic hospitals, which are serving mostly in universities that were exclusively for blacks, being Sefako Makatu, which used to be called Medunsa. Yes, that hospital called George Mukari Academic has never been built. It's in tatters. Also being King Edward VIII, which is now Victoria Mkenge in Durban. That's where I studied. It has never been built. And Nelson Mandela Academic. Yesterday, I was still speaking to Minister of Finance. He has opened a BFI, a budget facility for infrastructure program, for which we are going to apply for money to build these hospitals. We won't stop. The second thing I told you, we are going on with a rollout of a system called Health Patient Record Registration System. I told you about it. That registration system, which NHI cannot work without, which traces every patient from one hospital to the other, from one clinic to the other, from public to private, all those things, we are going to go on with them. We can't stop. In the budget that was read last year, we were given a sum of money, 1.3 billion rand, We said we are going to do 4 things. Among the things we are doing, we are buying hospital linen, we are buying beds, we are buying mattresses, we are buying pressure mattresses, we are buying bassinet for kids. In total, it's 1.4 million articles that we are buying for public hospital to spruce them up. We can't stop doing that. All those are in preparation. What the president has been asked to pause, he was about to proclaim a section of the act that allows us to establish a board for NHI. That's what we have stopped. And many other proclamations is going to do. But preparations, we can't stop. So the story that he has reversed is the same story whereby they were saying in order to suspend people, the president has to direct me. It's the same paper that is doing that because of the war against NHI. It's the same paper that puts my head there when somebody hires a person from jail. Anything that sounds negative, they attach there. And that's exactly the same thing. So it's misleading and deliberately misleading. Thank you.
Thank you, Honorable Minister. The next follow-up question comes from Honorable Brett. Over to you.
Thank you, House Chair. Minister, given the profound economic implications of the NHI, the serious concerns raised by economists, the private sector, healthcare professionals, patients, National Treasury, and the Minister of Finance, and given that the parties to ongoing litigation, including the President himself, have agreed to a court order staying the implementation of the NHI, pending a ruling on its own constitutionality, as you've just alluded to, on what legal basis do you persist to proceed with preparatory steps towards implementation, as if constitutionality is a mere formality, despite the risk that such actions may undermine the court order, violate your oath of office, and proceed without clear support from the partners within the GNU? Thank you.
I can see you are acting like a judge now. Yes, you are giving a judgment on things that are already in court because we are talking about economic implications, etc. We are challenging them. For instance, everyone tells us that NHI is going to cost the country 1.3 trillion. And of course, we have swallowed that, lock, stock, and barrel. Where does that 1.3 trillion come from? And you are saying economists and all that. We've got world-class economists in the world who have actually initiated the whole concept of NHI. They have written affidavits for us against what you are saying. Now, let me come to this 1.3 trillion. It is all, even in the court papers, that NHI will cost 1.3 trillion. Who came with that 1.3 trillion? It's Momentum Life. I'm not going to hide it, yes. It's Momentum Life.
Chairperson, I want to rise on Rule 47. Delegates may not converse aloud. The minister is trying to respond to the question, and Honorable Brett is busy interjecting.
All right, no, thank you, Honorable Manani. So I think that let us observe that protocol, that let us not be disruptive. Over to...
Yeah, yes, even the people who are making these claims have got different figures. Momentum Life says it's going to cost 1.3 trillion. Health Funders Association, to which Momentum Life is affiliated, has quoted 930 billion. There's another which quoted 450. Huge differences. Huge differences. Now, when Momentum Life brought this figure, I mentioned it deliberately so. In a meeting of doctors in Durban, I said what they've done is mathematical hooliganism. Yes, because I wanted to call attention to this. Of course, they were beaten by my words and they came to my office to complain why I said they are doing mathematical hooliganism. Because I said, how did you arrive at 1.3 trillion? This is what they said to me. That's why I can say it publicly. They said no, they were putting various scenarios in their own workshop. And the media picked it up and ran away with it. And I said, why don't you correct it? They said, no, we issued a statement. No media house is prepared to print it. And I said, when you were doing this scenario planning, how did you arrive at 1.3? And it was very simple. Simple high school mathematics, which shows that it can be true. They went to Council of Medical Scheme, take an average of what a person is charged when they go to private hospitals, which we all know are very expensive. They took that figure and multiplied by 63 million South Africans and said 1.3 trillion. Does it mean every South African is going to go into a private hospital? All 66 million of us, not 63, we're going to private hospitals. What do I do about these big hospitals that are there and doing better care? What do I... If you go to a private hospital now, you run out of money, they send us to you to us. Now, this estimate of 1.3 trillion assumes that we are going to close all the public hospitals. We have never said so. So we asked them to write us an affidavit to court to explain this thing. You can shake your head 1,000,000 times. I'm giving you facts. I am giving you facts, you're not a judge. So what you are saying is what I'm challenging. You want me to get defeated even before the matter is heard in court and say they are right when I know they are very wrong. Now, as I'm talking here today in front of you.
Chairperson, please save us from honorable breaths. Save us from honorable breaths. I'm standing on the same rule that I stood on.
Right, thank you, Honorable Manani. So I think the Honorable Press is true. You feel that a question to the minister, give the minister a chance to respond. Even if you don't like a response, but a response which is being provided, let us. But we can hear you, yeah. Yeah. All right. Thank you, Honorable Manani. So, Honorable, please.
Yeah, I'm left with 13 seconds. Well, there are human beings.
What are you raising, Honorable?
Rising on Rule 47, Chair.
Yes.
Rule 47.
Yes.
Dalela Mfweta. Chair, just be consistent, please. The whole house is making a noise, not just Honorable Breed. Everybody's conversing while he's making a question answer.
Right.
The whole house is doing it.
Your point of order is not sustained. I've made a ruling around that.
Admonish the whole house, Chair.
Continue, Honorable Minister.
Well, there are individuals who do not want to hear the truth. There is nothing you can do about that. You just don't want to hear the truth because you believe what you believe in is the golden truth. But that's not. You better listen to other people. Thank you.
Thank you, Honorable Minister. The next follow-up question will come from Honorable Kennedy from Limpopo.
Thank you, Chair. Honorable Minister. You know, we understand that the complainants came with different discrepancies. And again, in light of the so-called sanction agreement of that between 24th and 27th February, where the state agreed to park the NHI, what specific binding legal actions are being taken to address the public participation failures highlighted by the applicants in their complaints? Thank you.
Thank you, Honorable Kennedy. I don't know whether the minister will be in the position to answer that, because it's like him prejudging what is going to happen in the court, but you can do that.
Well, as far as I know, Honorable Member, the challenge about process is a challenge against NCOP. It is you, the NCOP, who must answer that. And the challenge is to the chairperson. Yeah, the papers were served to the chairperson of the NCOP and all the speakers of provincial legislatures and all the MECs of provincial legislatures. It is up to you, because you are the ones who are being challenged, that you did not follow normal procedures. In the National Assembly, the challenge was given to the Speaker of the National Assembly, the President, the Minister, etc. And as far as I know, they are responding. I, on my part, as the Minister, 2 weeks ago, because they gave us a deadline, I signed an affidavit of 1,000 pages explaining all these problems to the judges, which there's a man here who has presented himself as a judge and already made judgment about. I want the courts, I did not mention him by name.
Honorable House Chair, I'm going to object to that because that is not correct. I've never, ever purported myself to be a judge in this house or anywhere else. I am a lawyer, but I'm not a judge. I've never said that. That, sir, the minister is talking about.
Chairperson, I want to stand on Rule 48.
To him first, you know.
Point of order.
Yes, what rule?
Thank you, Chairperson. One would want to stand on Rule 48 that says that delegates may not be interrupted. And I want to read this one along with Rule 47, because here, what the other member is doing is interrupting the Honorable Minister and is addressing the chair. So please, can you rule on these two rule orders with regards to what Honorable Brett is doing? I thank you.
Thank you, Honorable Mananiso and Honorable Press, for what you've just raised. But to be fair to the minister, he didn't refer to any person. Yeah, he didn't refer to any person. He just said there's a man who's standing as a judge. As to who's that person, I really don't know. I don't know whether you know. I really don't know. So let us give the minister a chance to finish his work.
Okay. Honorable Chairperson, there is a man here who's passing himself as a judge in this very house. And I don't know why he believes he's a judge, because he's not. I've written my affidavit of 1,000 pages challenging some of the things that are being said there. It's up to the judges to sit and listen and make a ruling. Thank you very much.
Point of order. On the point of order, Chair.
Thank you, Honorable Minister. On what are you raising?
I'm raising on Rule 61, House Chair.
Yes.
Chair, I think it is incorrect for the minister to refer to members of this house, because he specifically says that there is a man here. And they are not men here, they are members of parliament here. They are honorable members of parliament here. It would be incorrect for you to allow him to refer to members of this house as just men. That can't be correct. And I want you to rule on that.
Thank you, Honorable Billy. Your point of order is sustained. Over to you.
Yes, Honorable Chair, I withdraw. There is an honorable member of parliament in this house who is passing himself as a judge, and he is not. Thank you very much.
Are you done, Minister?
Yes.
Without further ado, honorable members, we have come to an end to the question session. Honorable members, there's one for, actually it's confusing because it's ANC. Ne? That's why. Honorable Finis, the next follow-up.
It was supposed to be a question of the UDM. Yes. Honorable Minister, thank you for the response. In terms of the pausing of the proclamation of the first session, you've indicated that it won't have any impact on the preparations of the NHI. My question is, can you please clarify it if it's going to have any impact on the delivering of services from the government? Thank you very much.
No ways. No ways. We can't stop services from government under no conditions. Can we do that? We will continue providing services, whatever services in terms of our mandate will continue. In fact, there has already been a case like that. You will know that NHI is a branch incubated in the Department of Health, which is headed by DDG. When that DDG advertised post, Solidarity went to court and stopped him and said the NHI is still in court, we're still challenging it, you can't hire these people. The court said no, you can't stop the government from preparing and strengthening healthcare system and providing healthcare. That judgment has already been out and said no. So those 400 people were hired because the judge said you can't stop government from providing health services because you are in court. So that one will never happen, Honorable Member. Services will still be provided every day.
Honorable delegates, we have come to an end on the session of the Minister of Health. I would like to thank him for availing himself to answer the question and providing so much information in the few hours he was in. Thank you, Honorable Minister. You are free. Honorable delegates, I now call the Minister for Social Development, Honorable Minister Tolashe, to respond to question number 29 of Honorable Phillips. Over to you, ma'am.
Thank you very much, Honorable House Chair. Good afternoon to yourself and to all honorable members in the House, as well as people who are here to come and hear more on the work that you are doing. Thank you, Chair. As you would know, Honorable Chair, the Gender-Based Violence Command Center is an essential first point of contact in our response to the scourge of gender-based violence and femicide. The provision of psychosocial support services for survivors is critical to the reduction of the effects of crime and help them to heal, recover, and rebuild their lives. The decision by the President Cyril Ramaphosa to declare gender-based violence a national disaster has made it even more urgent than ever before. We have to improve the operational efficiency of this kind of a scourge. Accordingly, Honorable Member, we have embarked on a 9-point plan to address operational issues that, if left unattended, may hinder the effectiveness of the gender-based violence VCC. The plan involves, amongst other things, refurbishment of the building, procurement to fit the purpose office furniture, installation of bulk power and backup water tanks to minimize operational disruptions, as well as appointment of service provider to be on standby for maintenance-related issues. Honorable Chair, we're also upgrading fire extinguishers and addressing mental health issues such as stress and burnout in line with the occupation health and safety requirements. Chair, plans are currently underway to transfer the building from the Department of Public Works and Infrastructure to our own department so that it can be user-friendly, and we must use the user agreement. This will ensure that we have full control and management of the facilities to address any emerging issues. With regard to payments of service providers, I have directed the accounting officer to ensure that the payment of all valid invoices within a period of 30 days, as per according to the Public Finance Management Act, should be honored. I thank you, Honorable Chair.
Thank you, Honorable Minister. The first follow-up question will come from Honorable Finis from the Northern Cape.
Thank you very much, Chairperson. Greetings to the Honorable Minister, and thank you for the response on my question, Honorable Minister. Can you please provide a time frame for the implementation of these remedial actions that the department is busy with?
Thank you very much, Honorable Chair. Even though we did put timelines, this is extremely urgent as it deals with the one that is now agreed by the world that South Africa is rating as one of the worst countries insofar as this sketch is concerned. And as a result, we have tried and put every effort to make sure that the latest in 30 days, we should be able to put things in place, especially those that are in our purview, to make sure that there's no hindrance in the work that is being done by people whose better life is spent into those areas. Honorable Chair, we are saying this intervention will ensure that gender-based violence operation centers are optimally made to be effective without any disruption. Chair, we are quite committed into this because of what we all know now, what South Africa is going through, what we have put in place, and what then sometimes become a challenge, which all the time as the responsible executive authority should make sure that I move with a little bit of agility to resolve those. I thank you, Honorable Chair.
Thank you, Honorable Minister. The next follow-up question is coming from Honorable Du Plessis from Gauteng.
Thank you very much, Honourable House Chair. Honourable Minister, with these interventions, why is the GBV rate increasing in South Africa this year, when in other developing countries that have implemented the same interventions for GBV and IBV, such as Congo, Philippines, and Cameroon, the rate has decreased?
My apologies, Chair, I couldn't hear the question, please.
Can you repeat your question?
Thank you very much, Honourable House Chair. With the interventions that you've done as a department, why has the GBV rate increased in South Africa when in other developing countries such as Cameroon and Congo and Philippines that have done similar interventions, the GBV rate has decreased?
Thank you, Honorable Chairperson. Honorable Chairperson, the Honorable Member might be aware that gender-based violence and femicide is informed by a lot of issues. For instance, the crime rate in South Africa has created this, us having to go through the most traumatic area of where our people just die like flies. COVID-19. Honorable Chairperson, the fact that there are social ills that you are going through, on a daily basis, we learn other new issues that are coming through. As we are employing all this, at the same time learning out of it, we are still confronted with some of the things that I've articulated. And this is why the gender-based violence cannot be addressed by one department. It is now a gender-based violence sketch that is now being dealt with almost all the departments. For instance, you would know that the president has just set up an interministerial committee that must deal with issues of legislative framework that exist within our laws that seeks to confront gender-based violence. For instance, you would know that all of us, we have issues with the bail processes, a bail application on perpetrators. Majority of women and progressive people are suggesting that our legislating framework is too lenient when it comes to bail, which is what now, as we implement everything else, we should be able to look closer at the existing legislation framework and be able to amend them. So this is why it takes a little bit longer for us to be able to resolve this. And Chair, because of all other factors that we all know and are aware of, the gender-based violence takes longer to be addressed. Not because you are not doing anything as the House, lawmakers, not because our people are not doing anything, that is mobilization of this, the society, but because we are learning new things that are coming our way as we are trying to make sure that we deal with those that have been there but who have not been able to pick them up. The last one, Chair, the issue of paroles. Nobody ever came closer to the process of paroles, that sometimes the serial rapists are not just coming out in one time. When you do your follow-up, you realize that these perpetrators have been doing this for more than 2, 3, 4 times. And you realize that they get paroles because the department is following its own processes. And now we're bringing that closer to say, let's look at the processes that are followed when people are given parole, whether themselves are not contributing into what we are going through on perpetrators that are coming out of jail and repeatedly rape people. We did pick this up in the northern areas in the KZN, Mkanyagude, that a serial rapist is in fact now going back to jail because again he is raped. So this is what I'm saying, Chair, that it's not even 1 or 2 or 3 things that you must put in place for us to confront. It is about looking at the legislative framework that exists and make sure that what we have introduced with many hands on the deck, you are able to resolve this matter. Thank you, Honorable Chairperson.
Thank you, Honorable Minister. The next follow-up question will come from Honorable Siwisa from the Northern Cape.
No, thank you, Chair. Greetings, Minister. Minister, social workers are overworked and underpaid. While shelters which survivors are being referred to are falling apart, given that social workers play a significant role in ensuring that survivors of GBV receive counseling, and given the recent promise made by the President at his SONA address that there will be social workers at every police station to ensure a proactive response to survivors, what urgent steps have you taken to ensure the availability of these facilities? Thank you very much.
Thank you, Honorable Chairperson. Honorable Member would be aware of the fact that as a department, we are embarking on establishing these shelters. Of course, we have not covered all districts because we took the approach of DDM. But in this new financial year, we've planned ahead once again to have more. On the shortage of social workers, that is a fact. And this is why the President have announced that every police station must have a social worker. And now the process, as members would be aware, will be awaiting now for a process of departments themselves to pronounce on how many social workers for that particular financial year, which is 26-27, will they be able to absorb. Of course, social workers in South Africa are not a scarce skill. They are available. They were taken through by government, hence they now readily available. But we are now waiting for a process wherein SAPS itself will then take its share according to their budget to make sure that they absorb social workers. Ourselves, we're working with the institution that deals with that so that we can be able to work together with all departments to recruit and have social workers for the purpose of confronting gender-based violence and femicide, but also for all other social ills that you are going through. This is the approach, Honorable Chairperson. Thank you.
Thank you, Honorable Minister. The next follow-up question is coming from Honorable Brett from the Free State.
Thank you, Honourable House Chair. Honourable Minister, Let me start by telling you a story of Joyce. Joyce is a social worker in Kwakwa. I was fortunate enough to meet her and Honorable Noe as well when last year we went on our provincial week oversight there. She is specialized in dealing with children and children from households of abuse, yet she is unemployed, has been unemployed for multiple years. She is trying to keep up with the latest developments in social work and is trying by all means to find employment. She wants to serve her rural community of Kwakwa that has a need for social workers like her, but she is purely not finding employment. You have now, Honourable Minister, and it's very welcomed that you will go through a process with other departments and with SAPS to identify what need they have for social workers. But are you looking at having a database or asking these unemployed social workers to register to be taken up in these projects and your GBV centres? Because it doesn't help. We know what our need is, but we can't find these unemployed social workers. Thank you, Chairperson.
Thank you, Honorable Preet. Over to you, Minister.
Thank you, Honorable Chairperson. Honorable Member, you would know that social workers in South Africa are registered. So you don't have to go and look anywhere else. There's a database available. So it's something that, as I said earlier on, once again, to say, in fact, this government provided bursaries for majority of them to acquire what they have. Now, the process is, how do we then absorb them to come and do the work that we have articulated? But again, I must say, provinces are doing far better than all of us, because in their provincial budgets, to an extent, they are able to recruit that. I can send to the House submit on the states of provinces, but at national level, you are trying to make sure that we take some where we can in making sure that we have an impact in fighting gender-based violence. What the Honorable Member is saying is what I said earlier on. There are unemployed social workers, trained. I'm not saying they are social workers by how they look. They are trained social workers registered by the responsible institution. And therefore, this recruitment that is going to start is not going to be everywhere else. It's going to be a targeted recruitment. Thank you, Chairperson.
Thank you, Honorable Minister. We now go to question number 40, asked by Honorable Du Plessis from Gauteng.
Thank you very much, Honorable Chairperson. Honorable Chairperson, on the policy and legislative front, South Africa has several policies and legislative framework that are aimed at strengthening efforts to end gender-based violence and femicide. We are guided by these policies and pieces of legislation in the implementation of programs and interventions that are aimed at strengthening prevention, response, care, and support services for survivors of gender-based violence. Key amongst these is the Domestic Violence Amendment Act number 14 of 2021, the Sexual Offense Amendment Act number 13 of 2021, the National Strategic Plan on Gender-Based Violence and Femicide, and the policy provision on psychosocial support services, to mention but a few. In addition, we'll soon be tabling a gender-based violence and femicide support services bill to the Cabinet. Honorable Chair, the mandate of the department, as expressed in these policies and pieces of legislation, is to render care and support services to survivors of GBV. This mandate we do not take lightly, because for many survivors of gender-based violence, having access to safe space and receiving psychosocial support is the first step to break cycle of abuse. The timely provision of shelter services can save women in abusive and life-threatening situations. In terms of the National Strategic Plan of Gender-Based Violence, the department is responsible for Pillar 4, which focuses on strengthening and the existing response, care, and support services by government and civil society in ways that victims-centered and survivor-focused to facilitate recovery and healing. Other interventions under Pillar 4 include the expansion of Kuselega one-stop model through partnership with other Department of Public Works in particular. This involves the repurposing of dormant public facilities and shelters for gender-based violence survivors, scaling up the Boys and Men Championing Change program through the district development model. This is a social behavior change program that promotes positive masculinity. Appointing and deploying gender-based violence champions in areas identified as gender-based violence hotspots, but also providing financial support to community-based organizations that render prevention and front services to support gender-based violence and femicide survivors. Honorable Chair, these packages of services are complemented by Gender-Based Violence Command Center that provides telephone, professional psychological support, and trauma counseling services to victims, survivors of gender-based violence. These GBVCCs operate a national 24/7 days call center facilities manned by qualified social workers. The center has an emergency line number, which is 0800 428 428, supported by a Please Call Me facilities. In addition, we have a national emergency response team to provide immediate and positive response in the form of psychosocial services following an incident of trauma within 72 hours. I thank you, Honorable Chair.
Thank you, Honorable Minister. The next follow-up question is from Honorable Du Plessis. I think she's hard at work today.
Thank you very much, Honourable House Chair. Honourable Minister, all of these have been implemented, but gender-based violence has increased, while violent crime is reported to have decreased. Between July and September 2024, 3 months in recent history, 957 women were murdered by their intimate partners. There are numbers and there are humans behind each one of these numbers. 1,567 women survived attempted murder. Again, behind each number is a person. 14,366 experienced assault with grievous bodily harm. 10,191 rapes were reported. Not happened, just reported. And behind each number is a person, is a woman. Did the budgeted money get spent correctly, or are the plans failing these women of South Africa? Thank you.
Thank you, Honorable Chairperson. The honorable members will be aware of the fact that as individual departments, we put our prayers before the National Treasury on what we would love to have in each financial year, looking at the mandate that we have. Of course, you will still get a particular amount of money, which is now what you will be getting in that particular year. So forever you will have to look forward to get more. Even in the medium term, you would want to get more. However, you still get what is dedicated to yourself. Behind numbers, Honorable Chairperson, we won't stand here and grandstand to say that's not the case. We all agree that the gender-based violence in our country is now, in fact, moved from a scourge to a disaster. And this is why President have pronounced it that way. And this is why now all of us, we are hard at work in making sure that each and every strategy that we have put in place must not just work, but yield the positive results for us to be able to deal with this. Honorable Chairperson, yes, the statistics will be there, but you also think about those who are not even able to reach the police station for them to be able to register their cases. This is what we are going through as a country. This is what we are dealing with. This is why, Honorable Chair, we are even introducing programs that are talking to behavioral change, because this is in a mindset of a man. Of course, you would articulate the environment and everything else, but at the center, like the honorable member is articulating, there's a warm body behind that number. So we are very hard at work in partnership with the other sister departments, NPOs that are relevant, working with us and other international organizations that are also assisting us to deal with the scourge. Yes, Honorable Chair, we're not going to compete and really talk about the stats and so on, even to start to say, no, it's lower or it's up, because one is rather too many. We wish to live in a country that women are allowed to be walking into their streets of their country without fear. They could be in their space, in their houses, without having to be worried about those who are supposed to love them have changed to be their worst enemies. This is what we would want to see as a department in the center of that, working with other departments. We're doing everything in making sure that we get into that. Of course, it's a challenge because it needs all of us seated in this house to commit one to say, I will not be counted with those men that are alleged or some confirmed to be embarking on the gender-based violence. However, it will not just stop there. We should be doing something in making sure that we confront the scourge, and the house should also have those programs, which I know you have, that make impact in the life of our people, so that there will be no excuse on why men embark on gender-based violence. The young men must also, as I've just alluded to, the fact that we do have now programs that bring them closer, so that you can be able to talk closer to them and them be able to understand why there should be the support of women, but not women haters. So I'm saying to the Honorable Chairperson, to the member, the realization of the seriousness of gender-based violence and femicide has triggered that the president declare it as a disaster. Thank you very much.
Thank you, Honorable Minister. The next follow-up question comes from Honorable Sibande from Mpumalanga.
Chairperson, true wena. Ngivumele ukuthi ngibonge kumama uminister, umama uNokuzola. Obuye futhi abe upresident wabomama ngezimpendulo zakhe ezinohlonze. My question then ithi ke, Minister, how is the department ensuring effective coordination and legislative implementation in addressing gender-based violence and femicide? Ngiyabonga.
Thank you, Honorable Chairperson, for the question. Honorable Chairperson, as I said earlier on, we are working closer with the Department of Social Development was never part of JCPS, for an example, a structure that drives and monitors the safety of the country. We are now part of that because the gender-based violence became a scourge to start with, and now it's a disaster. This shows and demonstrates the commitment of this government and our department in making sure that we put a point to everyone else who might sometimes not understand because they are far from these issues, to say this matter is now a threat to the country, not only to women alone, but it's a threat to, and when you have a threat to the country must be able to take it into consideration and make sure that it employs a strategy that deals with that. And indeed, we are now part of the JCPS cluster. In there, we are able to give feedbacks on a daily basis whenever we meet, to get to hear closer when those women were able to get to the police station, because I repeat this, Honorable Chair, to say not all women get to the police station. Some die at home. Some die on the way. Some are never able to report this, because this who is embarking on this is sometimes the so-called breadwinner. So it becomes difficult for women to go and report a breadwinner, because the next morning she would not know how to look after her family. And this is why we are part of Pillar 4, because our intention there is to make sure that not only they forever become victims of gender-based violence, but they are able to be assisted for them to get out of those relationships and be able to lead and live their lives. So this is why, Chair, we are doing this. Chair, I'm not going to report about things that I said earlier on, but I want to just to articulate strategic interventions that we are employing in making sure that we deal with this matter. Chairperson, we are saying we are now part of the JCPS, which means even in police stations, we got to see to it that decisions and laws that are put in place are now implemented. Where they got to the police station, there should be that room that is dedicated to them to be able to speak closer to the responsible people without fear of being exposed. So this is what we are doing beyond us as the Department of Social Development with sister departments that are there working with us. Honorable Chairperson, I said earlier on, we brought strategic departments to even make sure that we look at the legislative framework that exists, and where there's a need, we are calling for the review of those. Chair, we are working with the capable NPOs and NGOs that have got history in that front of fighting with gender-based violence. Of course, with limited resources, we do share with them in number of cases. So, Chairperson, we do have a coherent approach that seeks to deal with gender-based violence and confront it in a systematic way, to an extent of saying this negative masculinity must be dealt with at a tender age, so that when he grows up knowing that their responsibility to defend their sister and make sure that he makes the environment safer for both of them. So this is how far we've been able to go, Honorable Chairperson. Indeed, there's a problem of gender-based violence and femicide in South Africa, which is now disastrous. Thank you.
Thank you, Honorable Minister. The next follow-up question is from Honorable Makesini.
Thank you very much, Minister. Ndibulele nge-comprehensive response yakho. Kodwa Minister, ndikuvila i-intervention enizenzayo nesi-Star Department. Kukho aba mama abaswelekayo bephethe iphepha ekuthiwa i-protection order. How effective are you doing ukumeka sure i-court they assist ingathi kuthiwa thatha nali phepha momnika, ngoba obviously ndiyamoyika ngokubalekela e-police station. How are we doing to assist and make sure aba bantu abasweleki bephethe amaphepha bapha besebezile e-police station sebezorepota, then kuthiwa usweleke nje uphethe iphepha kuthiwa bomnika, or the person abuye back azazoku-attacker because uyazi une-protection order. Sona senza njani ukusebenza ne-magistrate court and intensify, strengthen that system. Enkosi.
Manibonge kakhulu lunga lendlu ebekekileyo. Chairperson, as ordinary Department of Social Development, we might not be aware that in fact the protection order is a death sentence, if you can put it that way. Once she holds that paper, it means the next thing, she's gonna die. And this is why now we are working closer with the Minister of Department of Justice for her in the JCPS cluster to look closer into the issuing of that paper. Because as you might know, she's responsible to go around and look for him, for her to give him that. And already that exposes her to that kind of a killing or sometimes ensagale. We are now at the point where the minister is looking closely at that legislative framework to say whether the process that takes us to where the piece of paper is being released to be given to him, whether it is a right thing to say she must be responsible. I don't want to preempt her work, but when she's ready, she will come to say, this is how I've redesigned it, so that it is now not a death sentence to her, but it becomes a piece of paper and something that can really protect her into this that they are going through. So we have taken note of that. Women have come to say, and people are just saying, especially NPOs and NGOs, this is now even more dangerous. We have taken that into consideration and into working in the JSPS cluster. The Minister of Justice is looking closer into that. Thank you, Chairperson.
Thank you, Honorable Minister. The next follow-up question is coming from Honorable Dr. Skirkohan.
Thank you, Chairperson. Minister, more often than not, the LGBTQA plus community is overlooked when GBV is addressed. Therefore, Minister, how does the department collaborate with SAPs to support GBV victims and to ensure that SAP officers are properly capacitated to deal with the trauma a GBV victim is undergoing, especially with the LGBTQA plus community, so that there's not additional trauma through discrimination? Thank you, Chair.
Thank you, Honorable Member. The Honorable Member would know that this sector of people is being recognized in South Africa. For that reason, every piece of legislation that has been taken through these two houses will take care of that sector. And this is why the Department of Women, Children and People with Disability, in their arrangement, they're working very close with them. That's why we, as DSD, we are working very close in all branches that we have in the department, whether you call in the youth, in people with disability, but in the center with people who the HIV and AIDS program. I'm saying all the laws or pieces of legislation that are being processed, they are taken into consideration because by law we had to recognize them, and they are so smart, because if you don't do it, there's a possibility that they can take you to court. And this is why all the time we work with them, closer them, hear from them, and make sure that every new law or piece of legislation that is being processed, it must have taken their input into consideration so that you'll have a complete South African law or piece of legislation, or where we think or they have an issue to say this does not look after our interests. There are platforms that are open for them to engage, for us to find each other. And indeed, like we are saying, sometimes they are being taken for granted and become targets. This is the crime that we're talking about in South Africa that we must all fight. No one must be judged to an extent, must be hurt because of his or her belief. Thank you very much, Honorable Chair.
Thank you very much, Minister. Good afternoon to you and good afternoon, honourable members, ladies and gentlemen. Honourable Minister, we now come to question number 30. Question 30 was posed by the Honourable Feni from the Eastern Cape African National Congress, and it relates to drug abuse in schools. If you can reply to the question, please, Minister.
Thank you very much, Honourable Chairperson. Good afternoon to you. Honourable Chairperson, the proliferation and use of illicit drugs is a serious threat to our national development agenda, with studies indicating high prevalence rates among high school learners across the country. What is more alarming is that more learners start experimenting with drugs at a very early age, with some beginning to experiment with drugs at the tender age of 8 to 9. Given the foregoing, the most effective and sustainable approach to reduce demanding is building the resilience of the young people through prevention. The old-time saying, Honorable Chairperson, prevention is better than cure, it still holds so much value, especially as we confront the scourge of substance use and substance use disorders, which has now found its way to the school playgrounds. There are many measures in place to ensure drug-free schools, including the School Safety Program and School Health Program, both of which you are part of and is being led by Department of Basic Education. One of the mainstay interventions targeting young people is kimojo. Kimojo is a word that appeals to young people, which says, I'm fine without drugs. A youth-driven prevention campaign targeting in and out school children. To make it more relatable to young people, Chair, we also collaborate with recovering substance users. Remember those who become victims, and it sometimes becomes difficult to come out, but when they been able to at least fight the scourge, we then implement this program with key partner departments such as health, basic education, and police, local-based organizations that conduct consistent drug awareness with local schools. To date, Honorable Chair, we have reached over 500,000 learners in schools across the country. This work is guided by the National Drug Master Plan, which focuses on prevention, demand reduction, supply reduction, and harm reduction. Chair, we all know drugs have a devastating impact on our society, leaving a trail of destruction and misery for many families and communities across South Africa. Worse still, is often the most deprived areas that face the most drug-driven crimes and related health harms that suffer the most. Although it affects all ages, the impact on your youth is particularly devastating. Many of our young people who should be preparing for a future of hope and opportunity are instead drowned into cycle of addiction, school dropout, unemployment, and violence. Substance use disorder often coexist within mental health issues and homelessness. We know that substance use does not exist in isolation, Honorable Chairperson. It interacts with and often fuels other social ills, most notable gender-based violence and femicide. A more coordinating whole of government and society response is needed to tackle the growing challenge of illicit substance use and substance use disorders with a sense of urgency. This is the function of the CDA, which derives its mandate from Section 10 of the Prevention and Treatment of Substance Abuse of Act number 70 of 2008. Its role is to ensure that our work is multi-sectoral, intergovernmental, and fully coordinated across the society. This work is anchored in the National Drug Master Plan, our national blueprint for building a society free from harms of substance use and illicit drug trafficking. The National Drug Master Plan, Honorable Chair, sets out 7 national goals, including demand reduction through prevention, treatment and reintegration, supply reduction through SAPS and our many entities in law enforcement, and cross-cutting goals that address the social and structural drivers of substance abuse. These goals provide the framework for all the government and all of the society approach and to act in unison. I thank you, Honorable Chairperson.
Thank you very much, Minister. Mr. Feni, would you like to pose a supplementary question?
Yes, Chairperson. Thank you very much. Masibulele kakhona kuwe Minister ngengcaciso yakho ethe cha kwimibuzo nokusixhobisa usibonisa indlela i-department encedisa ngayo neqinisekisa ngayo into yoba ngabana iyalwisana nale ngxaki nale ngxubakaxaka ijongene nabantwana ezikolweni. Kuyabonakala ke Minister amalingelinge nenxaxheba yakho oyikhokelayo ukuzama ukulwisana nale ngxubakaxaka sewuhambele mgama kakhulu. Ndicela ke Minister uqonda nje into benye ba kule ulethu uyizamayo nalamalinge mhlambi nikhe nayijonga nayibona na eyona wona nobangela utsalela nohenda abantwana bethu ezikolweni ukuba ngabana mababekeke nokuba bechaphazeleka kule ngxubakaxaka yokusetyenziswa kweziyobisi. Enkosi Minister.
Thank you, Mr. Feni. Back to you for a reply, please, Minister.
Thank you very much, Honorable Member. Honorable Member, okokuqala nje, as you might be aware, sikwixesha lokuxhaphaka kakhulu kwiindawo esihlala kuzo, kwiilokishi ezincane nasezidolophini, kwiilali nakwiindawo ezinkulu. Ilizwe lethu lixhatshakelwe bubukho beziyobisi. Into yokuqala leyo sijamelene nayo singuMzantsi Afrika, ngoba xa kukho into ezinjalo, abantwana nabantu abatsha ngabantu bowulinga olinganisa nayiphi into. And in this case, if there is this availability of drugs around where people are staying, surely we won't be able to have a situation where children would not want to try it. But also, Chairperson, the fact that our people are also going through a violent community and society, this also informs that they can also be taking these drugs in order for them to make them brave. Abantu ngenxa yokukhohlakala bafuna ukuba babe ngabantu abakwazi ukulwa ngoba baneengxaki zokuhlala. Abantwana ingakumbi ezikolweni sifumana uba kukho abantu ababathengiselayo i-drugs, and sisizathu esithi amapolisa, SAPS in particular, must create a tighter belt into our borders in making sure that those that are coming that way can be stopped even before they get into our country. Because we believe uba kungcono siyinqande ingekenzeki. Xa sebesiya esikolweni, we are working with the Department of Basic Education for us to be deliberate in talking about the harms that are being created by those who are taking drugs, so that abantwana now is that time that you must be honest with them, talk to them so that they can understand what will be the problems if they start to take drugs. And lastly, Honorable Chairperson, this is why the law-abiding citizen must assist in this regard, because everybody knows where the drugs are being served. We all know where they're being sold. In every township or every village, in one way or the other, there will be this house or this area that is notorious in making sure that they're selling drugs. But lastly, this is why we must together fight with undocumented people that are in our country to make sure that we clean our streets, we clean our villages, so that we can be able to make sure that we close the space so that drugs cannot penetrate us. But where they are being found, we want to appreciate the work that is done by SAPS in particular in making sure that aba bafunyenwe neziyobisi bayajeziswa. We want that coordination to be tighter and SAPS to be stricter, and society to link with SAPS for us to be able to work together in making sure that we avoid this. It is a little bit awkward and devastating to find that our learners are starting to try at 9 years old. And this is why families must take it upon themselves to protect themselves. There's no teacher, Honorable Chairperson, that can be able to really deal with a 10-year-old that deals with drugs. Families themselves must close up. Government can do everything, but government will not be able to be in that house to look after that 7, 8, 9, 10, 11, 12, 13-year-old. So parents must take that responsibility to make sure that they look after their families. They look after their children in particular. Thank you very much,
Your time has expired. Thank you. The next opportunity to pose a supplementary question falls to the Democratic Alliance's Honourable Mokai.
Thank you very much, Honourable House Chairperson. Good afternoon to the Honourable Minister. Noting your response, and I think this is a very critical issue when it comes to the future of our country, the young people. Honourable Minister, the Safe School Protocol was launched by the Minister of Basic Education, Minister Siviwe, Kwagube, to address this and other safety concerns in schools. And I note that you have highlighted your partnership with DBE as well as with SAPS. But what I would like to know, and for the purpose of this question, to understand what are the tangible results of these interventions from your department in working with the SAPS as well as working with DBE to address the issue in schools of drug and crime on our school premises. I thank you, Honorable Chair.
Thank you, Mr. Mackay. Your reply to that question, please, Minister.
Thank you very much, Honorable Chairperson, and thank you to the Honorable Member. Of course, Honorable Member, this has not been a new concept. It's not new, but it was just revived and launched just to make it more effective because now the country is beginning to be overwhelmed. We have not been able to put that assessment tool to say what end result are we receiving. I won't stand here in this august house and mislead the house. I would just say we have not been able to put that to say how far have we been able to achieve or what impact are we making. Remember, the impact will not be visible with the immediate effect. We'll see it later in life, whether maybe if that particular school have admitted 500 people, 500 students, whether they are coming out with 500 at the very last, because some of them might have been lost in the process. Then we'll be able to say there's a problem here. Of course, other sectors like your health will be able to say, indeed, we are getting a lot of reports from this particular school on children that are embarking on, and social development as well, because it's us that is implementing through the CDA, the National Drug Master Plan. So it is that kind of a sectoral approach that will assist us to give you an end results on the work that you are doing. But I'm emphasizing to say, this is not a new concept. It has always been happening, but we want to renew it and reinforce and put more resources where we can and mobilize more stakeholders in making sure that we become many on this matter, because this threatens the future of the country. And all of us here, I know, we can't afford to have that. Thank you very much.
Thank you, Minister. The EFF's Honourable Machobeni will be the next one to pose a question.
Thank you very much, Honorable Speaker. Good day, Honorable Minister. The problem here, Chairperson, is the drug dealers that are continue to destroy the lives of our people. We need to deal with the cause as the government. Why these drugs not be banned? Because each and every time, sine challenges ezifacana nabazali bethu nabantwana bethu abaphelele ezintolongweni abafayo ngenxa ye-drugs. Why ngenye imini kule ndlu singakhe sibe nayo ibhili ethetha nge-drugs? Zivalwe tu because yeyona bhubhane obulala abantwana. Nonetheless, Minister, in light of the reports that about 30% of drug abuse causes are linked to family dynamic and poverty, which is ramped in areas such as the Eastern Cape province, what progress have you made in filling the social worker vacancies in the Eastern Cape Department of Social Development so as to ensure that rural learners that are referred for early intervention actually received it? Thank you very much, Minister.
Thank you, Honourable Machobeni. And your answer to that, please, Minister.
Thank you very much, Honorable Chairperson. I'm looking forward, Honorable Chair, to hear this house. Njengabenzi bomthetho, the lawmakers are seated here to sit and see whether we cannot deal with what the Honorable Member is talking about once and for all. Whilst I'm a member of Parliament, I'm also a mother and a grandmother. I stay in a township in Mlungisi in Queenstown, in a township. So I know exactly what we're dealing with here and what are the experiences. However, it's not me as the executive who can impose to say this must happen. Even though we're going through a very difficult process, I must agree with the honorable members. To an extent, abo mama in kwesinye isikhathi bebethi intambo ayibuye. Sibazwile. Kodwa sathi ngoba siyilizwe le-democracy and we wouldn't want to go back from where we are coming. Therefore, we should put in place, government must act a little bit, inject agility to resolve these matters. So I'm saying to the honorable members, what she's saying is not far-fetched. It is happening. But also, as I said, these people are staying in our villages, in our townships. The communities must be able to tell the police that, look at there's something that is happening. It's a house that starts to be busy around 9 in the evening until early hours of the morning. Therefore, it tells you that something untoward is taking place. So if you can mobilize our communities to say, in fighting this, let's also be together in reporting things that are a little bit suspicious to us. That's what I would want to say. Kona kona nje, we are in trouble. About the social workers, earlier on I responded to say, provinces are doing far better than we are doing in recruiting and absorbing social workers. I committed to say I can present to this house how far are we in making sure that we are dealing with this. Of course, again with limitations, because under the circumstances, every social worker should have been hard at work in making us to reverse what we are going through. However, we are noting and we are really appreciating the progress that you are making and the announcement that has just been made by the president. Indeed, the crisis in the Eastern Cape, for obvious reasons. As Minister Mtsoaledi, I was listening to him here that zonke izinto ezimbi ziqala kubantu abampofu. Ngoba ngesinye isikhathi bacabanga ukuthi ububha buzophela ma ebhemile. Ububha buzohamba ma umthetho wakhe umqondo wakhe ungasebenzi kahle. So in that way, it proves the fact that we must effectively make sure that the resources that we put to our society in making sure that there's bread on the table, like the SASSA grants, the project that can assist our people, like what the NDA is doing, must be one and kicking in making sure that our people don't lose what they would want to do or what they can do. But the government is always there to assist them, train them, those young ones, in making sure that they are ready to establish their own NPOs and NGOs and be able to have their small business being trained and join the economy or be the employers themselves. This is what we need to do, and this is what we are doing as the portfolio, because we are DSD, SASSA, and NDA, in making sure that to an extent we bump this that is a sketch to our society. Thank you very much, Honorable.
Thank you very much, Minister. The last supplementary question on this particular set will go to the Honourable Mhlongo from Mkhonto weSizwe Party.
Thank you so much, Chair, and greetings to you, Minister. Minister, as a drug activist on the ground, there are issues that we face with rehab centers. Ngizokhuluma nje la eKZN umfana omncane kuthiwa uSenzo owahlule ukuthola usizo lapha rehab. And I took it upon myself ukuthi ke nakube i-personal case yami. Only to get there, our social workers were not willing to assist because they believed he's been an addict for the longest time. Now, my question is with regards to Eastern Cape, having reported a problem, ama drugs in your tick, iyakhula, and ama learners are being exposed to it on a daily. I'd like to know, Minister, us indicate how many school-based prevention programs and rehab referrals have actually been implemented in the rural districts. Thank you.
Thank you very much, Honourable Mhlongo. And your reply, please, Minister.
Thank you very much, Honourable Chairperson. Honourable Chairperson, what the Honourable Member is articulating is correct. As I said earlier on, we have a legislative commitment in making sure that the drug master plan is being implemented, and that automatically will look after all the centers that seeks to deal with those who are already affected, but also other programs would make sure that we prevent those who are still clean. I won't say anything except to say it was out of order for social workers to say, just like that, people must go. I don't think that's the way of doing things, Honorable Chairperson. And this is why we are preaching Batupile to our officials to say, people first, abantu phambili, makusizwa abantu. No official has a right to say people must go back, especially, Honorable Member, that you are fortunate in KZN and you do have a center. There are areas where you don't even have that. So in areas where we do have centers, we expect our people, because they are own professional people that are recruited there, people who understand what they are supposed to do because they've gone through training and more knowledge. So they are expected to assist all the time. Of course, we know and accept the fact that sometimes they are hindered by the shortage of resources, but provinces and ourselves, we are working very hard. For instance, we have spoke with and we're being heard by the National Treasurer to say the CDA budget was a little bit not so significant. And now we have just identified that it has been now put in just a better figure, but it's not a figure that we can all be proud of. However, it has moved from where it was, which was plus 9 million, it is now at 14 million, which then we say at least it will make a bump, but we still need more. This is why we must work with all other departments. So I'm saying, Honorable Member, with schools, indeed, when they're at school, they end up into our facilities because DBE does not have that. And this is why I'm saying it is now upon us to sharpen up the resource mobilization, further training and intensified training to people who are services, our people, to make sure that those who are lucky to get into our centers, they get the necessary help so that they be able to come back and be reintegrated to the society and assist us, because they are better placed in understanding on where they were with this kind of a problem and how best they can assist ozakwabo. Ngiyabonga, Mgqinishlalo.
Thank you, Minister. That concludes question 30. We now move to question 52. Question 52 was originally posed by the EFF's member from Limpopo. That's the Honourable Kennedy. The question relates to administrative barriers facing ECD providers. If we can have your reply to that question, please, Minister.
Thank you very much, Honorable Chairperson. Honorable Chairperson, the function of ECD, that is Early Childhood Development, was transferred from Department of Social Development to the Department of Basic Education in 2022, as per the Presidential Declaration of 2019. Consequently, all matters relating to 1, streamline, 2, expedite a registration process for ECD, 3, including regulatory issues, they now fall under the Department of Basic Education. Chair, this is because ECD programs offer significant long-term benefit for families. We continue to work with DBE to roll out programs aimed at strengthening families and parenting support as per the revised white paper for families in South Africa. Through this collaboration, we encourage families to enroll their children in the early childhood education centers because we all know and are aware that education is not a luxury, but a necessary investment in the human capital of our nation. That would be my response, Honorable Chairperson. Thank you.
Thank you, Minister, for that. Noting that response, Honourable Kennedy, do you have a follow-up question?
Thank you, Honorable Chair. Honorable Minister, reports of 2021 to 2025 in Limpopo ECD centers faced significant challenges of registration. Many centers remain unregistered. So in light of this, Minister, you have launched the Banapile mass registration drive, as well as the e-CARE platform. yet thousands of centers in rural areas have no digital access or data to use your WhatsApp bots. In light of this, what other steps of intervention have you taken to manually register centers in rural and township communities which do not necessarily have access to internet? And what steps are being taken to eliminate the bureaucratic delays and corruption in the disbursement of subsidies, which often leave rural centers without funds for many, many months? Thank you.
Thank you, Honourable Kennedy. I do believe the Minister has addressed the fact that she's not responsible for doing these things. But Minister, would you like to have a comment on the member's question?
Honorable Chairperson, thank you very much. This honorable member is fighting with me. Whilst I appreciate and really understand what the honorable member is saying, but I don't want to mislead the House, honorable member. She's articulating statistics that is, for me, well researched. So I should not just thumbsuck the response, otherwise I'll be misleading the House. I can organize that concerned department should submit that follow-up, because in this matter, we're working together. Remember, children are our responsibility as per the Constitution of the Republic. So if there's that anomaly, then it will concern us. So I commit, outside all the procedures, that I'll make it a point that we find out what is the problem and send the response. I know DBE would be very keen in wanting to submit that response, and it will be responded by me, sir.
Thank you very much, Honourable Minister. Let's then get the next supplementary question, which would come from the Honourable Masumpa.
Thank you, Chairperson. Thank you, Minister, for all your response. The ANC won't be making any follow-up question. Thank you.
Thank you very much, Honourable Masumpa. Let's ask Honourable Skierkogel if he has a supplementary.
Thank you, House Chair. Minister, either this question was written long before when Julius still had friends, or this member has not noticed that the responsibility of ECDs have been moved to the Department of Basic Education some time back. So the real question is now that your department has one less responsibility, what exactly have you been doing with your extra capacity? Thank you.
Thank you, Honourable Skierkogel. Your reply to that, please, Minister.
On the last part of the question, Chair, was everything that talks to the DBE has been transferred, to the ECD has been transferred to DBE. It has been a long and tedious process, but it has been done and concluded. Thank you very much.
Thank you, Minister. And then the last supplementary on this will be from Honourable Breert.
Thank you, Honourable Chairperson. The Honourable Skierkogel almost took the words out of my mouth, but let me see, Honourable Minister, if I have another question for you. In terms of the transfer of ECDs from DSD to DBE, did we see any of those ECD centres being at a disadvantage because of that transition? I remember it's been long years coming. And how has that been mitigated to ensure that those that were maybe lost in the process have not actually, stumbled and fallen off the bandwagon? If that can maybe clarify. Thanks, Honourable Minister and Chairperson.
Thank you, Honourable Breert. Your reply to that, please, Minister.
Honourable Chairperson, honourable members would realize that the decision was taken in 2019 and implemented only in 2022. And it informs you that all other processes were followed in between to an extent of where then the implementation took place. I won't want to mislead the House once again and give a detail into that because I don't have it with me. But surely, if now you have ECD all of them falling under basic education, you would know that all the logistical arrangement would have been done. Even those who fell through the cracks in 2022, I guess by now you would have resolved them. Hence, I asked the honorable member to say if she thinks there's something that you can still do, we can still talk to our sister department to say there's a member in the NSOP who would want to hear more, which we can do. But that one, Honorable Chairperson, I'm unable to give that statistics because it was a 2019 decision, then implemented in 2022. Thank you very much.
Thank you, Minister, and I do trust that the Questions Office has taken note. Minister, we now move on to question 46. Question 46 was asked by the Honourable Mhlongo. It relates to the National Drug Master Plan. If we can have your answer with regard to question 46, please, Minister.
Thank you very much, Honorable Chairperson. On this particular question, Honorable Chairperson, while we have made considerable progress in the implementation of the 7 goals of the National Drug Master Plan in the last 5 years, we are the first to acknowledge that much more still needs to be done. The 7 goals of the NDMP are anchored on the 3 main pillars of the National Drug Master Plan, namely demand reduction through education and prevention, harm reduction through treatment services, and supply reduction through law enforcement. The implementation of the NDMP is the core responsibility of the Central Drug Authority, which derives its mandate from the Section 10 of the Prevention and Treatment Substance Abuse Act of number 70 of 2008. Its role is to ensure a coordinated national response that is fully multisectoral to address the scourge of illicit substance use and substance use disorders in South Africa. Honorable Chair, allow me within the limited time to highlight some of the key successes we have recorded in the implementation of NDMP, which is currently under review. We are currently consulting key departments as we prepare to take the 6th iteration of the National Drug Master Plan to Cabinet in the few coming days. With regard with Goal 1 of the NDMP, we have reached over 500,000 learners through education awareness and prevention programs such as I've alluded into earlier on, Kimoja, which means I'm fine with drugs. It is a campaign targeting young people. We have also partnered with Department of Higher Education Training, targeting students in the institution of higher learning across the country. Under Goal 2, the law enforcement agencies intensify supply reduction activities, including inspections, seizures, compliance operation, and the disruption of illicit drug manufacturing and distributing networks. As a result of these coordinated efforts, we're not only able to disrupt the criminal infiltration of illicit drugs into the country, but also to protect society from its harmful effects. Under the Goal 7, Honorable Chair, the JCPS cluster, which are part of, is currently rolling out the South African National Anti-Gangsterism Strategy to dismantle gang-related criminals' activities by addressing the socio-economic drivers of illicit drugs, such as poverty and youth unemployment. As I said, more still needs to be done. We look forward to working with the incoming members of the Central Drug Authority to address the scourge. On the question of evaluation, Honorable Chair, we intend to commission the Department of Planning, Monitoring and Evaluation for this purpose to provide feedback on the impact of the National Drug Master Plan. I thank you, Honorable Member.
Thank you very much, Minister. Honourable Mhlongo, I'm sure you have a supplementary question.
Thank you, Chair, and thank you, Minister, for your response. Minister, I'm aware that the CDA and the stakeholders had the issues with the draft that you first submitted because it was not inclusive of the civil society. So I'd like to know, when is the CDA approving the final draft, and also what measures are being used to monitor the effectiveness or the success of the master plan? Thank you.
Thank you, Honourable Mhlongo. Please reply, Minister.
Thank you very much, Honorable Chairperson. Whilst we appreciate the good work that has been done by the CDA, we don't take it lightly that they've worked under very difficult circumstances. We are now at a point where we are renewing. Within no time, the portfolio committee is going to deal with the nomination of new members. We pray that we'll have concluded that process by end of March, which then informs all of us that now the process that, again, as I said earlier on, the Department of Monitoring and Evaluation will also assist us in making sure that we do the right thing with the necessary speed. We'll be able to have this new body that will be now workshopped and be inducted accordingly, given the challenges that are even more pressing than what we had 3 or 4 years ago. So I want to suggest to say to the honorable member, we are hard at work in making sure that as we renew the mandate of Central Drug Authority, we take along the positive work that they've been able to do under very difficult circumstances, but also engaging the Department of Monitoring and Evaluation so that they can talk closer to us to say we are on point in dealing with this. Remember, when you do it ourselves, majority of time we are too much inward looking and you don't find yourself in yourself. But when you put a mirror, you'll be able to have that. This is the process that we are embarking on. We guess by April, latest May, we will have been able to do all this, Chair, and have this structure that is in demand more than any other time. Thank you very much.
Thank you, Minister. Mr. Sibande?
Thank you, Chairperson. Minister, ungihlaba umxhwele ngokuba zonke izimpendulo zakho zihlaba esikhonkosini. Ukusho ukuthi umbuso wabantu uyachuba. Honorable Minister, we understand that the implementation evaluation is only going to be done during the financial year 2026 to 2027. My question, why is the department delaying the evaluation of the National Drug Master Plan? Thank you.
Thank you, Mr. Sibande. Your reply, please, Minister.
Thank you, Honorable Chair and Honorable Members. Honorable Members, I indicated to say we're on it now as we speak. Hence, I'm talking about the other departments like monitoring and evaluation. Hence, I'm saying we are renewing the mandate. I don't want to say we're doing everything in our power to make sure that this structure exists for the correct purpose. It must also be properly. When you say properly, because if you don't have enough resources to drive this, it's like we are saying things for the sake of saying. So we also want it to be properly resourced, like we did already, and we won that battle with Department of Treasury. We are also making sure that all departments are playing their individual role. Remember, it's not a matter of one department, which is Department of Social Development. It's a matter for all government departments. So we encourage them to say they must come and join us to make sure that the CDA is well represented according to the Act, but it also does what is expected of it. And we do what is upon us to make sure that it is properly resourced. Of course, Honorable Chair, working with the provincial government and local government, which the CDA that is coming out of the office now have done good work insofar as that coordination is concerned. We really congratulate them in the good work that they've put in place, and a lot of progress has been registered in this regard. Thank you very much, Chair.
Thank you very much, Minister. Let's go now to the Honourable Adriansa.
Thank you, Honourable Chairperson. Honourable Minister, we're sitting at twice the global norm of substance abuse. We're sitting at 15%. So what is really important that we need a successful drug master plan. And this is heavily dependent on the swift coordination between the multiple departments, particularly social development, health, and SAPS. And this especially comes to play when you want to admit a substance abuse victim. I'm calling that by want of a better name in this case. Because if we don't have those systems in place to admit quickly, these people fall through the cracks and end up in the streets again. So I want to know what practical, real time, although it's on paper, although it's in the plan, what real oversights and mechanisms are in place to ensure that the silo working of these departments are going to be stopped, that we can ensure that there's accountability and that they will work in cohesion to the effect and effectiveness of quick admission of patients who need to be treated. Thank you, Honourable Minister.
Thank you, Honourable Adriansa. Your reply to that question, please, Minister.
Thank you very much, Honourable Chairperson. Indeed, Honourable Chairperson, what I've just articulated in the oiling of the machinery, that is the CDA itself, for it to be fit for purpose. The fact that I made mention of the fact that at least there's little that has been injected in it. Of course, as I said, we would wanted to see more. However, we managed to get what which we must appreciate. Of course, I spoke about the coordination between the different departments, strengthen that. But I also registered the progress that have been made by the CDA that is just completing their time spent in the office. Those, for me, lay a good basis on what then needs to be done. But the relationship that we have created and being part of strategic committees, because you can't speak JCPS if you don't talk about the work that is being done by CDA, because they are the ones that are able to tell you at a VD level what is going on, because they are the one that, more than the department itself, they are the one that are in the local municipalities in different wards, therefore in different VDs, and they are the one that must fit to this structure for it to be able to understand what are the challenges that they are going through and design programs that are relevant to what they are going on a daily basis. So, Honorable Chairperson, I want to assure the honorable members that the renewed structure, the recognition of the work that was done by the CDA that is getting out of office, the intensified coordination between departments, the resourcing of the CDA itself, the responsibility of Department of Social Development is then central into this, which is myself. I have that responsibility and I take it very seriously that I will not really go to bed peacefully if the structure is not doing as according to its expectation. So this is what we have put in place, Chairperson, in realizing and understanding the challenges, in realizing, understanding where the country is, in realizing and understanding the devastation that our grandmother are going through. Because these 16-year-old, when they got involved to be in the drugs, they become a problem at home first more than in the society. So we have got that responsibility, because remember, in that grannies, we have got recipients of grants. So if you don't look after that, you don't make sure that the CDA is up and running and fit for purpose, your grant recipients are vulnerable. The little money that you are providing is going to be redirected in one way or the other. So whilst you are dealing with this particular challenge, you will be resolving a lot of those challenges that are really devastating our elder person. They want more money because they can't afford. When you listen closer to them, like we always do, you get to hear that now they have to resolve the problems of a homestead. And they are not supposed to be like that. They are supposed to get the little that the government is providing, just for them to get those things that are really demanding to their health. So if you resolve this particular matter, you would have resolved a number of challenges that our country is going through. Thank you so much, Honorable Chairperson.
Thank you, Honourable Minister. Let's get the next supplementary question from Mr. Mampuru.
Thank you, Chair. Chair, there is a guy called Bongani in Impumelelo, Devon. I first met him in 2018, and since then, he have been in and out of rehab. He said to me, it took him 6 weeks for him to be addicted to drugs, and then after rehab, it only takes him 2 days for him to be re-addicted to drugs, which then tells you that there is enough exposure of drugs to our people. Having said that, Minister, given that substance abuse continue to destroy families and communities, particularly in poor working class areas, despite the existence of the National Drug Master Plan, what measurable outcomes have you achieved since the implementation of the current Drug Master Plan in reducing drug abuse, drug-related crimes, and youth dependency on substance? And which failures, gaps, and delays have you experienced in implementation of this plan at the provincial and municipal level to save young men like Bongani? Thank you, Minister.
Thank you, Honourable Mampuru. Let's hear your response to that, please, Minister.
Thank you very much, Honorable Chairperson. Thank you, Honorable Mampuru, for the question. At some point, Honorable Member, we did not know whether we should have a CDA or what, because we're all overwhelmed with this kind of a scenario. Remember, especially Africans, it has never been a norm where a 11-year-old will start smoking, let alone smoking sophisticated things. At least we have moved as a country to have been able to have an act that dedicates the government and all its partners to deal with the scourge. But not only have it, but we are at this stage where we are implementing it. Of course, with the challenge that we've just experienced, sometimes you wonder whether you are on it, because the scale of people taking drugs is moving with a speed that I've never seen. But we should appreciate the fact that at least with having established CDA according to the Act, means whether I like it or I don't like it, by the Act, it is compulsory for me to implement it. Therefore, the government is forced itself by developing that Act to make sure that it does look at the sketch and be able to resolve it. But not only that, we are now able to say there's a structure that is now winding up, a structure that has recorded a lot of progress, regardless of the challenges that we are going through, regardless of the fact that at some point, the very people who are on drugs, unfortunately, they hide that they're taking drugs. For the fact that people who are on drugs, sometimes they look like me. You won't suspect them, because they do it in a manner that will make you not to be suspicious, which those are extremely dangerous. But also now we know that at schools, there's a strategy that seeks to address that so that you discourage young people to take drugs at that age. And as such, we are saying at some point, having established designed the drug master plan, have CTA in place, we are now saying the first cohort is getting out of office. We have registered the progress that they've made. They have themselves articulated the challenges that they are facing. And standing here, I have now a responsibility to drive this a little bit faster to say the challenges that have been identified must be resolved and addressed with the necessary speed. Now I've got better resources than I had earlier on. But not only that, Honorable Chair, I have traversed almost 5 provinces since I came to office. When I go and do the truant program that is called iCrop, I meet directly with the community, with elder people, people of the medium age, with youth in particular, to talk closer and introduce to them possible processes or institutions that can assist them as they get out of this. They can be trained and assisted to be business people, or to have their own business, or to run their own NPOs, for them to be able to talk about their experiences and teach those that might be trapped into this. I am not saying this honorable member is perfect. For the fact that we said earlier on, this is a part of the disaster, because if we leave it and if the states like the honorable members were articulating, majority of people who get involved into gender-based violence and femicide in particular are people who have gone through drugs, especially femicide. Because femicide talks to the spouses and partners of people who right in the house, they get involved into gender-based violence. So I can't stand here and boast that this is perfect. It is dealing with everything. A lot still needs to be done. And this house also has got a responsibility to assist in this regard, to say what else needed to be done. Of course, within the legislative framework. Thank you very much, Honorable.
Thank you, Minister. Your time had indeed expired. Thank you, honourable members. We now move to the last set of questions. Before we do so, I'd just like to, as usual, acknowledge our visitors in the gallery and tell you all that you are most welcome. Two special visitors today, young leaders. We have Mr. Maynard Creer and Mark Kabongo. Mr. Kabongo is a medicine student at UCT, so welcome to our chamber, and it's great to have you here participating in the People's Parliament. Minister, the last set of questions, as I say, emanate from, there we go. Thank you very much. Minister, the last set of questions emanate from question 32. Question 32 was asked by the Honourable M.F. Mokwele, the ANC's member from Limpopo, and he asked about the provision of humanitarian relief and psychosocial report through the South African Social Security Agency. If you can reply to the question, please, Minister.
Thank you very much, Honorable Chairperson, and thank you to the Honorable Member for the question. Honorable Chairperson, I can safely say, but boast to say, a lot has been done during the devastation that our people went through, especially those that are in Limpopo, KZN, Mpumalanga, of course, earlier on, Eastern Cape as well. Remember, Eastern Cape at some point got involved into this kind of a devastation. I want to report to this House, Honorable Chairperson, to say immediately the said news were communicated with us, SASSA in particular, as a readily available vehicle that seeks to deal with people's devastations on a daily basis. We got to provinces. It was informed because of the extreme rainfall that resulted in the devastating floods that submerged homes, destroyed crops, and disrupted livelihoods, pushing families into hunger and displacement. In other areas, we lost people, and may their souls rest in peace. This happened in Limpopo, Mpumalanga, KwaZulu-Natal, and Eastern Cape. As portfolio, wasted no time. We deliver on our mandate by providing a rapid response to meet the immediate humanitarian needs, including psychosocial support to the affected families and communities as they recover and rebuild their lives. Some of the worst affected individuals and families were temporarily accommodated in shelters, through which SASSA and department provided cooked meals, trauma counseling, and psychosocial services. In Limpopo, SASSA provided immediate relief through the social relief of distress by providing hot meals 3 times a day for 7 days. We provided mattresses, dignity packs, including baby care packs for displaced people who were placed in temporary shelters in Vembe, Mopani, Capricorn, Sekhukhune, and Waterberg regions. A total of 1,070 people received SRD in a form of cash assistance and food vouchers. Chair, working in collaboration with other key partners, one of the most important things we do during disaster is to ensure that learners do not miss out on the available school time. Accordingly, SASSA provided school uniform to 113 learners. Chair, in Mpumalanga, SASSA provided cooked meals cook meals, I'm sorry, for displaced families and immediate human assistance in the form of old age grant for family that tragically lost one of their own to cope with the financial burden. 17 learners received school uniform. In KwaZulu-Natal, the worst hit was Amajuba District Municipality, where SASSA provided humanitarian relief in the form of hot meals again and all the goodies. In addition, SASSA provided food vouchers to a total number of 35 people. Honorable Chair, social development is part of the Ministerial Intergovernmental Committee on Disaster Management, which comprises political leaders from across 3 spheres of government, including South African Local Government Association and the National House of Traditional and Khoisan leaders to ensure a coordinated response by all sectors to the implementation of disaster management intervention. Chair, we are grateful to the many partner organizations, including Spark Group, ShopRite, Gift of Givers, Old Mutual Foundation, Faith and Community-Based Organization, and too many others that I cannot mention, for the time allocated and the resources that they contributed. They join hands with the government in responding to the humanitarian needs of the affected individuals and households. Sithi kubo nangamso. Thank you very much, Honorable Chair.
Thank you, Minister. Mr. Makwele, would you like to pose a supplementary question?
No, thanks very much, Chair, and thanks very much, Honorable Minister, for your response to my question. Very excellent response. Honorable Minister, my question to you is that the rain has affected a lot of services in affected provinces, like the province which I'm coming from, Limpopo and other provinces. My question to you, Minister, is that has the rain disrupted the receipt of grants in the affected areas? I thank you.
Thank you, Mr. Makwele. Nice and short. Your answer, please, Minister.
Honorable Chairperson, what we can report in this house is that no one missed his or her grant during the time. SASSA made it a point that everyone received his or her grant in time, unless there were just technicalities of not being able to access the road, which was within a very short space of time was addressed. No one has missed a grant during the devastating time. This is our commitment to our people, Honorable Chair, to make sure that for all our sins, every time, consistently, 19 million people are being paid on a monthly basis by SASSA as it's according to its own mandate. Thank you very much.
Thank you, Minister. Let's look to the Honourable Swart now for a supplementary question.
Thank you, Honourable Chair. Good afternoon, Honourable Minister. You've answered part of my question on the support that you offer. But, Minister, these victims are there living in these temporary shelters since the floods in 2022. But now, the other part of my question that I really want to pose to you, given that more than 3 years have passed since 22, the floods, then what concrete steps, Minister, and timeline has your department set together within relevant housing authorities to ensure that the displaced families still living in these temporary shelters are relocated to permanent housing? Thanks.
Thank you, Honourable Swart. Please reply to the question, Minister.
Thank you very much, Honorable Chairperson. Honorable Chairperson, as I have alluded to the fact that we belong to the disaster management that includes many government departments, and in part of that is Department of Housing and Human Settlement. This is an integrated effort to make sure that we address what is the problem. Ours is to make sure that during that time, we make sure that the services that talk to us directly are being served all the time, even when people are in awkward areas. We will not be able to give a convincing answer about housing of those people because it is not within our purview. However, we can assure the honorable members that all that DSD is supposed to provide, it is being provided consistently and coherently. Thank you very much, Commissioner.
Thank you, Minister. The next question will be posed by the Honourable Beza.
Thank you very much, Chairperson of the House. Minister, during our oversight of floods with the Select Committee on Public Administration in Makhado and Nkomas, we found together with Honorable Makesini that in Ward 17, Ward 19, Ward 30 in Nkomas, the reports of delays and of distribution in Skumansdal and Masbegel of social relief support through SASSA in Mpumalanga, which would have been an unfortunate gross violation of Section 195 of the Apex law of the country, in tandem with Section 9, which prohibits, would provide for the prohibition of unfair discrimination in the delivery of services. Can the minister account for the glaring coordination failures which have left vulnerable households exposed to hunger, trauma, and neglect after the floods, taking into account the mandate of the department to ensure basic nutrition, shelter, and its involvement in the disaster management? Thank you very much.
Thank you, Honourable Beza. Your reply, please, Minister.
Thank you very much, Honorable Chairperson. Earlier on, I articulated the role of the DSD portfolio on areas where unfortunately, people have gone through the floods. In that, Chairperson, there is no way that we can tolerate tendencies of wanting to or having confirmed to have ignored part of the people who are affected. Because this that you are doing is not, we're not doing people favor, as the Honorable Member have articulated the legislative framework that compels us to do what we are doing. So if there was that kind of untowards, I wish it could have come to us quite earlier so that we resolve that matter with the immediate effect. I was like, the CEO of SASSA had to be based in Limpopo. I was physically in Mpumalanga. We were in both provinces at the time because they were at the same time almost affected. We were there not because we wanted to go and demonstrate anything, but we wanted to make sure that nobody in the assistance during that time is being left behind. If there's any kind of that unfortunate situation, I wish the honorable members can write to us so that we can follow this up and make sure that there's a tangible answer to give back on what then transpired. Because standing here, Chairperson, I'll not be able to give convincing answers on why that was the case. In Mpumalanga, we have a SASSA, we have a new regional manager, Mr. Mahlangu, who is responsible to make sure that SASSA business is ran accordingly. We work very closely with the Department of Social Development to make sure that as a portfolio, we provide these services. So I encourage honorable members, when that situation arises, just talk to us. Talk to me, talk to the CEO of SASSA, so that we can be able to resolve the matter on the spot. I was in an area where it's a farm. Whilst they were affected by the floods, the owner of the farm was evicting those people. I had to be there and sit there to make sure that that does not happen, because the laws of this country does not allow that. You can't evict people whose roof has been taken away by this wind or the rain, and you say, well, now this is your piece of land, so people must go. So we are dealing with such tendencies and things that sometimes you cannot imagine. I'm trying to demonstrate our commitment in making sure that when we give those services to our people, no one is being left behind. I was in Mthatha, Chair, just as closing. We got to understand in the morning when those people who are staying in that area, because there were floods, remember, in the morning you'll find more than 80 people. During the day, there's no one. Find few people. In the evening during supper, there are most 100 people. During nighttime, there are fewer people. Those are the things that you must also manage to make sure that your numbers are consistent with what we have registered, because there are difficulties sometimes. Thank you very much, Honorable Chair.
Thank you very much, Minister. And Minister, please, I do apologize for the disruption from my side. Honourable members, we come to the last subsequent follow-up question for the day, and that will be posed by the Honourable Masumpa.
Thank you, Chairperson. Thank you, Honorable Minister, for the response. My question is, why was the intervention only in Machuba district in KwaZulu-Natal?
Thank you, Honourable Member. Your reply, please, Minister.
Thank you very much, Honorable Chairperson. Honorable Chairperson, we are not the one who determines where the disaster is, but the structure led by COCTA is the one that does that. So when that has been determined, then we follow that process. And then after having followed that process, we then provide the services that we are responsible for. So surely, because we were at Majuba, we had this experience. Our people were taken through with the service that we provide. We now convinced that everything went according to the book, because in the process of providing these services, Chair, our audit committees are hard at work in making sure that we don't under or overspend, or there's no money that is being spent in a manner that will not be able to account. So we got to areas where there's that kind of a determination. Under normal circumstances, indeed, SASSA and the DSD portfolio, we do get to see areas where we have identified some challenges of the communities through our CNDC to make sure that our people are being looked after, even when there is no disaster. Thank you very much, Honorable Chairperson.
Thank you very much, Honourable Minister. As you resume your seat, we'd like to thank you for your attendance today. Honourable delegates, that I'd like to thank the Minister, which I've done. I'd like to thank all MECs. I'd like to thank the permanent and special delegates in attendance, and also the SALGA representatives for availing themselves for the sitting. Honourable delegates, that concludes the business of the day, and the House is adjourned until next week. Thank you.
Recording stopped.
Thank you.